resident online teaching program by Tamil Nadu and Pondicherry chapter of IRA and UIRA. So we start off today's session with Dr. Anbarsu starting the case discussion and mock examination. Dr. Anbarsu requires no introduction. He's a consultant radiologist from Coimbatore. Also, he is the cross-sectional imaging and he is also the SS head for ICRI. Anbarsu sir, can we start off? He's also
yes, Murali, thank you very much. And yeah, that's all fine. For the PGs who are going to exam, it doesn't matter.
Yes, it does. So we have for the first case, we have Dr. Anusha from Stanley Medical College. She'll discuss the first case with you.
Yes, okay, excellent. Anusha, you are there?
Yes, sir.
Okay, excellent. We have about 236 audience, so we'll try to make it this thing. So welcome to everyone who for this completely different initiative to having a live Viva on webinar. It's really a little bit unnerving for the PGs. In a way, it's better for them because they don't have to see face. The other thing is that they cannot get any clue from my expressions, so that's a good thing, in fact. There will be all around people will be watching, and they think that why this is being talked and why this. But if you're actually standing in your hotspot, then you will know 50% of your knowledge immediately disappear when you start presenting in front of the audience. So let's start with the first case, which is already sent to Anusha about 1 hour before. So let's start. Anusha, I'm showing you the first slide now. So what I want to do is go through a basic format. So if you want me to move the slide, I can move the slides. I want you to first introduce the film. Okay, just introduce the film, introduce the image, and then tell me the findings, observations, and your possible interpretation and diagnosis and differential diagnosis. And if you want to make any further comment on the whole process of management, please let me know. So for the next 1 minute or 2 minutes, I will not be talking, you will be talking. It's your time, it's your presentation. So I want you to start from the point and then finish. If I have a doubt, if I have a question to ask, like in the exam, I will ask you, but I will not interrupt you for starting from your introduction to your complete differential diagnosis. All right?
Okay, sir.
Okay, Anusha, you start now. If you want me to move the slide, just let me know.
Okay, sir. Non-contrast CT axial sections of brain showing ill-defined ISO2 hyperdense lesion involving the right temporal bone with opacification of right middle ear cavity, external auditory canal, and opacification of right mastoid hair cells, extending posteriorly to the posterior cranial fossa, involving the right CP angle cistern with mass effect over the brainstem and cerebellum, and the lesion also extends inferiorly in the other sections, inferiorly up to the carotid canal. There is permeative destruction of the mastoid part, squamous part, as well as the petrous part of the right temporal bone. There is a permeative sclerotic destruction noted. Also, retrosigmoid decompression craniotomy has been done, and the post-op changes related to it is also noted with adjacent edema. The next slide shows a contrast enhanced sections of the suprahyoid neck, where there is peripheral enhancement of the lesion with central necrosis. The lesion appears to cause minimal splaying of ICA and ECA, and also the ICA and ECA are pushed laterally by the lesion. I'm not sure about this finding, sir, but there is some changes in the tongue noted involving the right ipsilateral half of the tongue. So the patient is a 35-year-old male with complaints of headache and difficulty in speaking. So with these findings, my principal diagnosis will be an extensive paraganglioma from jugular foramen, which may extend into middle ear cavity and also inferiorly up to the carotid canal, or it could be a skull base osteomyelitis because of an external artery canal infection. But in the history, there is no history of fever or ear discharge or diabetes. And other DD will be skull base metastasis, but he's only 35 years old. I'm ruling out a nerve sheath tumor because nerve sheath tumor will cause smooth scalloping of the adjacent bone, but here there is more of a permeative sclerotic destruction. So ruling out schwannoma. Meningioma is still a possibility, but meningioma is more of a focal lesion with adjacent sclerotic, permeative sclerotic type of destruction. But here it is more extensive, extending up to EAC and medial up to Petrus apex. And other DD will be endolymphatic sac tumor posteriorly, but that is also more focal, and there will be other features associated with VHL. One point against paraganglioma is the enhancement pattern. There is no significant contrast enhancement in the axial CECT sections of neck, sir. So principal will be paraganglioma followed by skull base osteomyelitis.
Okay,
Other DDs?
that's gone.
Sir?
Gone. Yeah, please go ahead.
Other DDs will be less probable DDs will be skull base mets, meningioma from jugular foramen or endolymphatic sac tumor, or a schwannoma from jugular foramen, which is not possible here because there is no smooth scalloping, sir.
Okay, so I think that was an excellent presentation, Anushya. You already passed the film. Okay, you passed the film. Whatever this particular images and this particular description, you have passed it. Let me go on because just to tell you one more point. Let us say that whatever image I have shown you from the beginning is itself a post-contrast image. If you look at the basilar artery, it is showing some enhancement
Showing
here.
enhancement.
All right.
Okay, sir.
Yeah, it's showing enhancements. It's showing, you can see the basilar artery showing enhancement. So you can see the two vertebral arteries are seen. So what we are dealing with is and also the whole thing is a only post-contrast scans I have shown you. And
Okay,
the
sir.
deletion is enhancing following contrast.
Following contrast.
Okay. Does that
Okay.
change your differential? Yeah. It's as you described correctly, this enhancement is here. There's a little bit of erosions and irregularity, opacification of the middle ear, mastoid, and external ear. And you described this beautifully, and you also picked up the craniotomy defect. Okay, so now does your differential diagnosis change knowing that this is all post contrast scans?
Because there is enhancement. No, sir. I'll go with first DD will be jugular.
Yeah. Okay.
Foramen.
So yes, so your diagnosis is not going to change. Now let's come to the point where you thought that there is what looks like a necrotic area here, and sort of you said it's trying to splay the external carotid artery and internal carotid. We are actually at a little bit higher level of carotid bifurcation. We are almost at the level of, you can see the deep branch. This is actually one of the branches of external the sort of ascending pharyngeal artery sometimes comes there, as you can see it here. So this is the internal carotid artery. So if this is internal carotid artery, what is the adjacent structure, which is sort of tortuous? I agree, it is a little bit tortuous, going a little bit more laterally. But if you go back,
jugular vein.
Yes, exactly. So what is happening to the jugular vein?
Thrombus or?
Excellent. Yes, jugular vein is thrombosed. It's enlarged. and you can see it here and sort of rim enhancement. So there is the something which is invading into the jugular vein, and you
Jugular vein.
picked up beautifully what looks like there is some low attenuation area in the right half of the tongue. So there is one more image which I did not send to you, but I'm going to show you now. Okay, I'm going to show you now. It's on this spot. One more slide, and this is that slide. And what does it show?
So there is hemiatrophy of some edema is there in
Absolutely.
the right half of the tongue, sir.
Yes.
And
There is edema and low attenuation, which is suggestive of fatty infiltration, and therefore this is
fat
hemiatrophy
infiltration.
of the tongue. Yeah.
And
So
some changes in
excellent.
the
So you
rectum.
have picked up a lesion. Yeah, some change the product. Let's ignore that for the time being. So we have got a skull base enhancing lesion, which is involving the petrous bone for some reason, but it is also going through the jugular fossa, causing jugular vein thrombosis, and it is also causing hemiatrophy of the tongue. What does the hemiatrophy of the tongue mean actually?
Hypoglossal nerve involvement, sir.
Yes, hypoglossal nerve palsy. Okay, fine. So now you described a lot of differential diagnosis, as you beautifully said. Let's go with one by one. One is you said it is a glomus a tumor from the glomus jugulare, which is probably involving. What type of you said it is a permeative destruction, but what you could have asked is, I would like to see the bone windows of
Bone
this
window.
patient to assess the actual erosion. Yeah, you should have asked for it. I haven't given you the bone window, but you could have said, ideally I would like to assess the bone erosions using bone window. That is a good statement to have during the viva, because if you're not given, if you wanted to, we all have to assess everything in the correct windows, otherwise we will miss lesions. So if you are going to assess commenting on the bone, you can suspect there is something wrong with the bone, but if you want to assess the actually what is happening to the bone, you want to see the bone windows. The appropriate windowing is very important. Correct. If you're not going to comment on the lung nodules without seeing the lung windows, you will
Tongue
be
window.
seeing, you won't comment on the lung node with, so it's like that. So you have to see, you have to make a statement saying that I would like to assess the further the right petrous bone with. So actually the petrous bone showed not much destruction. As you said, there is an associated infection, inflammation, some automastitis was there in this particular patient. There was some irregularity and erosions were there. And I didn't give you the history of diabetes, I didn't give you the history of ear discharge. It was not there. This patient had some ear discharge in the past, but at the site of some, at the time of presentation with the symptoms of difficulty in speaking, he did not have any discharge history. So yes, there was a finding which is related to it, but as you can see, this lesion is not completely eroding or destroying. It is causing some irregularity along the posterior margin. You can see this is very smooth surface on the left hand side, but the posterior margin of the right petrous bone looks a little irregular. So
Irregular.
your differential diagnosis was beautiful. Yeah, it's actually good. And so the biopsy was done for this patient. Yes, you correctly picked up posterior fossa craniotomy tumor. The first thing you said was glomus tumor. Glomus tumor tend to cause, as you said, permeative type of or eroding type of bone destruction. And the jugular fossa, I didn't show you particularly, but this is the closest you can get to jugular fossa. As you can see, there's a little bit of irregularity, but not like a destruction for the size of the lesion, as you would normally see. Okay, so jugular fossa is possible, but the pattern of bone destruction is little unusual. The second one you said was osteomyelitis. Yes, it is possible, but this type of enhancement like a mass and osteomyelitis is a little unusual, but post-operatively things can change and things can, and you wouldn't do a posterior fossa craniotomy for an osteomyelitis, right? Obviously, we're dealing with some sort of a mass
Mouth.
lesion, but you correctly suggested that. So what was the other option you said? You said it could be a meningioma. In
Meningioma.
fact, that is the diagnosis of this patient. Yeah, meningioma was the diagnosis. You said that there was this biopsy was proven to be a meningioma, which is enhanced, which is infiltrating the dural margin. It is also infiltrating into the jugular vein, because the jugular folds has got meningeal cells which can infiltrate by the meningioma, so it can go into the jugular fossa, and because of its sheer volume, it is compressing the cranial nerves there, and it is causing paralysis of the 9th cranial nerve, 12th cranial nerve, resulting in hemiatrophy of the tongue. Okay, now I'm going to ask you 3 more questions, the viva questions. All right. So excellent, you passed the film. You did very well, and you picked up this hemiatrophy even without this film. Okay, now tell me the posterior fossa bone involving lesions. just differential diagnosis of bone involving lesions. You said most of you already mentioned meningioma, osteomyelitis, endolymphatic sac tumor, paraganglioma, METs, everything you mentioned. Anything else? Anything else? Bone involving lesions at posterior fossa?
It can part of generalized bone disorders like Paget's or can also affect.
Okay, something like an erosive lesion rather than a sclerotic lesion. Erosive lesions. Erosive lesions. Anything else?
Metastasis.
Yeah, metastasis is a good differential diagnosis. Okay, let's go to the next one. What are the causes of jugular vein thrombosis? We think it is a very, very innocuous finding, but jugular vein thrombosis for radiologists is a very, very important thing. As soon as you see jugular vein thrombosis, we have to think few things and we have to look for few things. Tell me the causes of jugular vein thrombosis, which are important for radiological things. For a
So
radiologist.
any infection, inflammation, or a neoplastic process in the carotid sheath.
What infection in particular? Okay, what neoplasm in particular? You already said that. You said about meningiomas, you said about glomus jugulare, tumors which can invade jugular vein. Any other jugular vein invading lesions?
A part of Lemire syndrome or
Very good, excellent. So you're answering the first question, which is then infection. Infection. So infection, Lemire syndrome is an
oral
important thing. What
infections
is
or
the
parapharyngeal
bacteria?
infections.
Yeah, what is the bacteria in Lemire syndrome?
Fusiobacterium.
Necroporum, correct. Fusobacterium
Necrophorum.
necroporum. Okay, correct. And what about so what are the other causes of jugular vein thrombosis apart from the infection? You said one, any other neoplasm in head and neck?
Squamous cell, any malignant tumors like
Any malignant tumors which is showing metastasis to the jugular chain nodes can erode into the jugular vein. Common things are, as you said, squamous cell carcinomas and also papillary carcinoma of the thyroid. When it is showing metastasis, yeah, they can invade into the IJV and can cause jugular vein thrombosis. Any other cause of jugular vein thrombosis? See, if you're doing ultrasound of neck, say you detect the jugular. Traumatic cause, yes, it's possible. Okay, I'll tell you a scenario. You are doing an ultrasound and you. Can you hear me?
Yes, sir. Catheters.
Okay. Catheters, very good.
Basically,
Excellent.
we are exceeding the time for the students.
Okay, fine.
Exam time is over.
Okay, fine. Exam time is over. Let's go on to the final thing. Okay, let's just go through the differential diagnosis. The diagnosis was right: meningioma skull base, invasion of jugular vein, the hypoglossal nerve palsy. And differential diagnosis, you answered very well. METs, meningiomas, myelomas, chordomas, and chondrosarcomas are the bone eroding one of the other lesions. Glomus tumor, and of course, you said about endolymphatic sac tumor, and of course, mastoid and medullary carcinomas are differentials there. And jugular vein thrombosis, tumor thrombosis, like lymph node, skull base lesions, neck masses, infections, you correctly said about Lemire syndrome. Hematological disorders, lines and tubes, you correctly said. And ovarian hyperstimulation syndrome. One other thing you need to think about is you always check the upper extremity veins, which has got associated thrombosis, about 77% of patients. Okay, and there is something called Paget-Schroeder syndrome, androgen abuse, polycythemia, effort thrombosis, people who are going to gym and lifting heavy weights. Okay, excellent. Thank you very much, Shia. I think you did very well.
Thank you,
I think I can hear everybody clapping across Tamil Nadu for you. Thank you very much, Murali. Let's move on to the next one. Is the
Thank
next
you.
one online?
Yes, thank you, Anushya. Next is we have Dr. Renusha. She's from CMC Law. Doctor, yeah. Anushya, you have to log out.
Okay, sir.
And
just close the window.
Hello. Good morning, sir.
Yeah, we can hear you, Anushya.
Good morning, Renusha. How are you?
Fine, sir.
Right. So you're ready for the Viva?
Yes, sir.
Can you hear me?
Yes, sir. I
Okay,
can hear you, sir.
Have you had breakfast?
Yes, sir.
Okay. Have you had breakfast? Okay, fine. That's the usual questions asked by the internal examiner during your Viva, isn't it? Probably. Kana. And probably Shyam or Shyam may not be asking this question. Okay, right. You are ready, Renucha? Am I
Yes, sir.
pronouncing your name right?
Yes, sir. Yes, sir.
Okay, fine. Okay, so let's start. This is a young female with breathlessness, which was given to you. I should have given you a little more difficult film, but there you go. So this was the chest radiograph, which was given to you earlier. Let me just see.
Yes, sir.
So can you see the chest X-ray?
Yes. Shall I start,
Yeah,
sir?
you start talking. You start now, and I will move. And as I told the previous candidate, you start with introducing the films, describe the findings, give your diagnosis or differential diagnosis, and further management as you would see appropriate.
Yes, sir. So I've been provided with
Go
chest
ahead.
X-ray
It's your
and
time.
chest X-ray and CT images of a young woman with breathlessness. This is the frontal radiograph of the chest, which shows trachea central in location. The cardiomediastinal silhouette is normal. There are few subtle nodular opacities which are noted in bilateral lung zones, lower zones of bilateral lungs. Bilateral CP angles appear normal. No evidence of any consolidations or patchy haziness noted. The osseous structures appear normal. In chest X-ray, so there was no much findings except for those nodular opacities which are seen in bilateral lower zones.
Okay. You said osseous structures are normal. Are you able to see all the osseous structures in a matter of about 30 seconds?
No, sir.
But you are able to. You got it. Okay, exactly. So use the word grossly.
Yes, sir.
All right. Okay. Next. You want me to move the slide?
Yes, sir. Yes, sir.
Okay. Yeah, go on.
So this is the axial CT section of thorax in lung window, which shows bilateral, near-symmetric, patchy areas of ground glass opacities noted in bilateral lungs. These ground glass opacities are peribronchovascular in distribution. Along with the ground glass opacities, there is also a area of consolidation which is noted in the left upper lobe in a perihilar location. And also there are few ground glass nodules which are noted in bilateral lung fields in a centrilobular distribution. These ground glass opacities are peribronchovascular and there is areas of subpleural sparing. In the subsequent images, sir, in the last image, where the lower lobes are visualized, there are areas of few focal areas of air trapping also noted. The next image. So.
This is the next image I provided you.
Yes,
I
sir.
think.
The last this one's yeah. Here there are few focal areas of ground air trapping which are noted in the bilateral lower zones in the posterior aspect. There are no evidence of pleural effusion. No areas of any bronchial thickening or bronchiectasis or interstitial septal thickening noted. Combining both the chest X-ray and CT finding, summarizing the imaging findings, there is bilateral, patchy, near-symmetric ground glass opacities along with areas of consolidation and ground glass nodules and focal areas of air trapping. So I'd like to give a list of differentials. My first differential would be acute hypersensitivity pneumonia. The points favoring are the presence of patchy ground glass opacities which are symmetric and subpleural and they are peribronchovascular in distribution, presence of ground glass nodules which are centrilobular in distribution, and few areas of air trapping. And the second differential I would like to give is viral pneumonia such as COVID-19. Although ground glass opacity, multifocal ground glass opacity is a predominant finding which is described in COVID-19, but usually they are the typical findings are peripheral and bilateral, but in our case there is subpleural sparing and it's peribronchovascular in distribution, so I've kept it as a second differential. And the third differential I would give is PCP pneumonia, but I would like to have a history of immunocompetency of this patient. And final diagnosis, pulmonary edema, but the cardiac silhouette appeared normal. It could be a non-cardiogenic pulmonary edema, but there is no interstitial septal thickening which is noted in this case. No pleural effusion also seen.
Okay, excellent. That's a very good description and a very good differential diagnosis. I'm going to show you one more, which I didn't send to you earlier. Just one more image of the same CT finding. Just to describe it for me.
So this is a diffuse ground glass opacities, a coronal image, reformatted image, which shows diffuse ground glass opacities involving bilateral lung fields with area of peripheral consolidation noted in the left lower zone, with few areas of with adjacent bronchial bronchiectasis and bronchial wall thickening. And there are consolidations in the right perihilar location also, sir.
Okay, exactly. So whatever you have described in the axial findings, we are almost seeing the same findings here. Now, you said the first differential diagnosis is possibly acute hypersensitivity pneumonia.
Yes, sir.
What is the usual distribution of the hypersensitivity pneumonitis?
So they are central in peribronchovascular distribution with upper lobe involvement, upper and middle lobe
Upper lobe
involvement.
involvement.
Yes, sir.
Yeah, here, which is the predominant involvement?
Predominantly lower lobes are involved, sir.
You said the first differential diagnosis. I know.
Yes.
Okay. Hypersensitivity pneumonia. So who is talking in between? It's always like that. When we are doing a Viva, there is always somebody at the backup know everything. It's okay. By mistake, it comes through. Thank you, Ransha. So yes, so hypersensitivity pneumonitis tend to occur in the upper and mid zones. What is the classic description of the density? Like a smoke inside the alveolus.
Yes,
It's one of those, description for the density. It's almost like a ground glass density as you would see in an acute hypersensitivity pneumonitis. But what will be the important history related to hypersensitivity pneumonitis?
The patient will have symptoms of fever, chills following within 12 to 24 hours of exposure. There will be a prior exposure to some allergic antigen.
Okay, yes. So this patient did not have any pets. This does not have any allergies. Okay, and it was done very recently. If you look carefully, the scan was done on the 1st of July. So what will be your diagnosis?
So viral
And it is
pneumonia,
Excellent.
pneumonia such as COVID-19.
Absolutely. Okay. So now, what is as you said, what is the classic? What do we call it as a COVID-5 type of appearances, and what is COVID-4 type of appearances?
So a COVID-4 type is high suspicion for corax, and in COVID-5 it is very high suspicion for COVID-19. In CORAT-5 we'll have typical findings such as multifocal ground glass opacifications, and there will be the distribution will be bilateral and symmetric in location, bilateral, peripheral and basal distribution, and there'll be areas of crazy paving noted, and also vascular thickening will be seen. Those are the typical findings, and atypical findings are central distribution and peribronchovascular distribution, and lymphadenopathy and more apical distribution rather than basal distribution.
Excellent. And what would you call this as? Either is it 3, 4, or 5?
4, sir. CORAT's 4.
This particular patient.
Yes, sir. Because of the peripheral.
Okay. And what are the atypical features we are seeing? Yes. Okay. Right. Excellent. Now, what other infections can mimic this appearance apart from COVID?
So pneumocystis.
And is there a possibility of differentiation?
PCP pneumonia, HSV can cause ground glass opacity, CMV can cause ground glass opacities, and respiratory syncytial virus can also cause ground glass opacities.
Absolutely. So most viral infections can have. So diagnosis COVID, you correctly said that. And you cannot sometimes difficult to differentiate that by influenza virus, other cytomegalovirus, adenovirus, RSV, which you correctly said, MERS and other viral pneumonias, and some bacterial pneumonias also can mimic like this appearance. And as you will go back to the original coronal image, you would have seen that there is an area of consolidation at the right lower lobe.
Yes.
And if you see that alone, you might even you can see that here in the right lower lobe adjacent to the diaphragm, that almost looks like a bacterial infection. But that is an accident. So what will be the next management here?
PCR, sir.
Okay.
And
so you are maybe in a hospital setup, you just incidentally detect this in this patient who has got these symptoms. So what will be the severity here in this patient?
Moderate. So
Roughly. Yeah, okay. So moderate means what will be the best management option?
isolation and start them on symptomatic treatment, sir.
Okay. And observation, regular observation with
SpO2 and
yes, regular observation for any SpO2. Correct. Okay, absolutely. And ready to move into the ICU whenever is needed. All
Yes.
right. Okay, excellent. I think Renisha, you did very well. You passed the film and you did beautifully. Thank you very much. Murali?
Yes, sir. Thank you, sir. Thank you.
Thank you, sir.
Renisha.
Thank you, Renisha. Next, we have Dr. Surya Prakash, sir.
Okay.
Dr. Surya Prakash is from Kilbuck Medical College.
Right. Excellent.
Good morning, sir.
So now, good morning, Surya Prakash. How are you?
I'm good, sir.
Okay. More than you, your Professor Devi Meena will be tensed up sitting on her toes. Is that right? Yes, she's so fond of her residents that she almost like a mother taking care of all the children. Right. I'm sure she's hearing somewhere, and I'll get a feedback immediately in WhatsApp in 2 minutes time. Let me go on to the next case, Surya Prakash. This is the third case which was given to you. I'm just waiting for it to load. So are you going to the hospital now, or because of exams you are on leave?
We are going to the hospital, sir.
Going to the hospital, and that is the right answer always to say in front of everyone, right? Okay, excellent. Now, this was the case given to you?
Yes, sir. So 42-year-old
fine.
male.
So the next 2 minutes, I will not be talking. Yeah, go on. Go on.
42-year-old male with complaints of cough and left-sided chest pain. The given frontal radiograph shows a large radio-opaque left paraspinal mass with broad base towards the mediastinum. The superior, lateral, and inferior margins of the lesion are very well defined. The medial margin of the lesion is not defined, making an obtuse angle with the mediastinum. I am able to see few areas of calcification within the mass. The mass appears to sill out the aortic knuckle and proximal part of the descending thoracic aorta. No obvious vertebral anomalies. I could not comment about the rib erosion in the frontal radiograph, and no obvious bony pathologies seen. The CP angles are normal. No obvious parenchymal changes visualized. The given lateral radiograph confirms the posterior mediastinal position of the mass that was described.
Surya Prakash, we are losing you.
No obvious no fat fluid level, no fluid air level within the lesion, no obvious fat density areas within the mass. Next, I would like to go for plain and contrast CT of this patient. So the selected axial lung window and soft tissue window of this patient shows a large heterodense mass lesion with areas of calcification in the posterior mediastinum abutting the esophagus and the descending thoracic aorta. And here I'm able to see areas of rib erosion along the posterior aspect close to the vertebral body. No obvious scalloping of the vertebral body, and I don't find any intraspinal extension or widening of the neural foramina in the given images. There is no obvious parenchymal changes in the given lung window.
Okay, I'll move to the next one.
Yes, sir.
Yeah.
The provided post-contrast axial and coronal images shows a heterodense lesion with heterogeneous enhancement pattern and extending for about 3 to 4 vertebral body length. And here again, I am not able to make any intraspinal extension, and I think the rib erosion is there. No evidence of extrathoracic soft tissue component noted here. No obvious mediastinal lymphadenopathy except for a tiny prevascular group of lymph nodes here. No obvious axillary lymph node enlargement. So with this, I would like to sum up my findings as a heterodense posterior mediastinal mass with areas of calcification and rib erosion without obvious intraspinal extension. My first principal diagnosis is posterior mediastinal neurogenic tumor. And other less probable differential diagnosis could be an hyper-enhancing lymph nodal mass with areas of calcification. I am ruling out thoracic aortic aneurysm on CT images, which was one of my differential diagnoses in plain radiograph. And lateral thoracic meningocele was also a DD for this case in a plain radiograph. And depending on the density and absence of intraspinal extension, I'm ruling out lateral thoracic meningocele. I would like to further proceed with image-guided biopsy for this case to confirm my principal diagnosis of neurogenic tumor.
Okay, Surya Prakash, that was an excellent presentation, very clear and very articulated. That's beautiful. But I'm going to pick you on one finding here, right? I'm just going back to the previous image. And can you see on your left-hand side, there is a mediastinal window, and below that, there is a bone window of a plain CT, correct?
Yes, sir. The bone window
Yes.
shows
Now,
obvious
can you
dilution
describe
of
that bone window? Okay, what else? Apart from the erosion, what else it is showing?
The lesion, sir.
Yes, yes, that's important, isn't it? A plain CT showing so many hyperdense areas, that means what? It has to be either calcium or ossification or hemorrhage. One of the three has to be there, isn't it?
Yes, sir.
So there are multiple calcifications. Now, you given your differential diagnosis, which you started with the neurogenic tumor. How
Yes,
many neurogenic tumors show such type of calcifications?
Sir, neuroblastoma can show stippled calcification, sir. But it is
Okay.
unlikely in this age group.
Yes. So why did you start your differential diagnosis with an unlikely lesion? Any other neurogenic cause which will have so much calcifications?
I don't think nerve sheath tumors like neurofibroma or schwannoma will not have such calcifications, sir.
Yes. So would you like to keep neurogenic tumor as your first differential diagnosis in this particular age?
No, sir. No, sir.
Okay, fine. So what will be your second? You said was new lymph nodal mass.
Yes, sir.
Okay, but you said it is arising from it is probably eroding the fifth rib, correct? Some rib
Yes.
which was posteriorly. So if there is a rib eroding lesion, how many lymph node masses actually do rib erosion in chest?
So invasive masses only will cause rib erosion, sir. That is why I thought it could be a posterior neurogenic tumor with rib erosion, sir.
No, that we have discussed. That you said now you have moved it already because of calcifications. You said neurogenic tumor is less likely, and you moved it. I agree with the posterior rib erosion, no doubt about it. But you told second cause as a lymph node mass with calcification. Which lymph node mass with calcification erodes the rib?
Highly unlikely, sir. Like sometimes
Unlikely.
posterior mediastinal mass can be a Castleman's disease, but the contrast pattern of Castleman's disease is not here. It is a hypervascular mass, sir.
And how many nodes will be there in Castleman's disease?
So it can be unicentric or multicentric, sir.
Yes, but this is definitely not Castleman's, isn't it? It is
Yes,
not
sir.
like this. Okay, fine. So whatever the differential you said, you already excluded thoracic aortic aneurysm and lateral thoracic meningocele.
Yes,
Okay.
sir.
Now I want you to think. So the differential diagnosis you gave all sort of unusual and rare causes of disappearance. So common things are common. So I want you to go back a step back and you have to start thinking. The main findings here are a mass lesion. That's one finding. Second thing, it is definitely showing extensive calcifications. Okay. Third thing, it is definitely involving the rib. Right?
Yes, sir. So to
Okay.
be
So
a
based on
primary,
this, give me a differential.
so if it is arising from the rib, it should have soft tissue component on either side of the rib, sir, like Ewing sarcoma of the rib. So it will have soft tissue component.
You don't use the word should. In imaging, never exists should or never. It should have a soft tissue component on either side of the rib is not valid statement, because we know that things can present either side, but so use the word like less likely or unlikely or more likely. That is more validated. All right.
Okay,
So
sir.
you said it is so the key thing we have is a mass lesion, calcification, rib erosion are the main things, correct? So based on that, you said it could be a Ewing's tumor, but is that the calcific pattern in an Ewing's tumor?
Ewing's tumor will not have chunky calcifications like this, sir.
Exactly.
Like
Okay.
primary bone tumor,
on.
chondrosarcoma arising from the rib can present like this.
Okay. What else?
Adskin tumor.
Okay, that's a good thought, but it will have more soft tissue component and less
Yes, sir.
calcifications like this. Okay. Any other DD? Okay, good.
Mediastinal.
Now I'm going to show you one more investigation which go on.
Sometimes chronic mediastinal hematoma can have calcifications like this.
Yeah, eroding the rib.
Rib erosion is unlikely in such cases, sir.
Unlikely. Okay, very good. Okay. Now I'm going to show you one investigation which I did not send to you. Okay, it's going to be on the spot. And this is the investigation. Describe it for me. What is this investigation? Describe it for me, and what is the finding?
So anterior and posterior MIBG image.
How do you know it is MIBG? No, hold on, Surya Prakash. Where does it show MIBG here? How do you know it is MIBG? Just by looking at
mostly normal
No,
uptake.
hold on. Why did you say MIBG?
Since I was thinking
Normal
of
uptake
neurogenic,
in where?
like it has some uptake in the nasal region, bladder. It has some uptake, sir.
Okay. No, it is MIBG scan. Which MIBG scan shows this bone so clearly? You can actually count the ribs. You can actually see the entire vertebral column. You can see the pelvis. You can see the skull. You can see the humerus.
Bone scan.
It is a simple bone scan.
Okay, sir.
right? So today's homework, you have to go and look at all the MABG scans you have, look at all the bone scans you have. You have to differentiate. You cannot jump into MABG scan. And we already excluded that discussion because the
not in your
age group was not fitting with neuroblastoma. So now approach it with an ordinary bone scan that is more relevant and that fits with an appearance. Tell me.
So it shows the lesion shows uptake. So it can be a primary bone tumor arising from the rib.
No, describe it for me. Describe it for me.
So the anterior and posterior bone scan shows left paraspinal avidly uptaking mass, probably with vertebral. There is invasion. There is uptake in the vertebral body also, sir, adjacent to the mass.
It is related to the same patient. So what would you conclude now?
So it can
I'm
be
not
a
showing any different patients, same patient.
primary bone tumor, sir, arising from the rib.
And most likely?
With that calcification pattern, I think it can be chondrosarcoma.
Okay, excellent. Okay, right. Yes, it is a chondrosarcoma rib. Finally, you're able to reach the diagnosis. You could have told it, and I think you're going to have some words from your professor based on your approach. Now, tell me the bone-forming lesions can arising from the rib. As already I asked you that question, I think. So the other question I'm going to ask you: what are the types of chondrosarcoma? It's the next level question.
It can be a de-differentiated chondrosarcoma, well-differentiated.
Okay.
Mixed chondrosarcoma.
Okay.
Secondary chondrosarcoma arising from earlier primary lesions, sir.
Excellent. Such as?
Like from osteochondroma, that chronic complication of osteochondroma, chondrosarcoma can arise from the cartilage cap.
Very good. Excellent. Okay, so this is the list from Radiopedia directly. Okay, you call it first as a primary. You can have a conventional intramedullary chondrosarcoma, juxtacortical, clear cell chondrosarcoma, mixed chondrosarcoma, mesenchymal chondrosarcoma. There is something called extraskeletal chondrosarcoma, and there is a de-differentiated, which you already said that, and there is a secondary cause, which you again said that arising from pre-existing cartilaginous lesions can be osteochondroma, primary or hereditary multiple exhastosis, or even enchondromas, Ollius disease and Maffucci syndrome. Okay, so this is the types of chondrosarcoma you should be aware. So remember, when you have a rib lesion with calcified or ossified bodies within a large lesion, think about chondrosarcoma, and it is a sort of a favorite for examiners because it is something which is very easy to diagnose, and the key thing is to pick up the bone elements on the or cartilaginous elements or calcified elements on the plain CT. Surya Prakash, well done, and thank you very much.
Thank you, sir.
Okay, excellent. Okay, thank you very much. So,
thank you, sir.
Thank you, sir.
Murali?
Thank you,
Surya Prakash. Yes, sir.
Thank you.
Surya Prakash. Yes. Next, we have Dr. Gokul, sir.
Morning, sir.
Yes.
Morning.
Gokul, how are you?
I'm good, sir. How about you, sir?
I am super.
Gokul
I'm asking
from
questions, so
Sri
I'm
Ramchandra
always
University,
okay.
sir.
Okay, excellent.
So can you hear me, sir?
Okay,
yes,
Gokul.
we can hear you.
Okay.
Yes, I can hear you well. Right. So let's start with your first case. So it's a female presented with left proptosis. That was the history given to you. So you start
Yes, sir.
describing, and I will move the images as you would require. Yeah, go on.
Okay, sir. Selected axial sections of a contrast and enhanced brain showing suspicious filling defect in the left MCA, sir, with the distal reformation from the posterior circulation. And in the right frontal sinus, there is a soft tissue density lesion, sir.
Right or left?
Rest of the left, sir, sorry, left. Rest of the vessels appear normal and the brain parenchyma appears normal, sir. Can I see the next
Okay.
image, sir?
Do you want me? Yeah, close. Sure.
In this image, we can see that there is a medial erosion of the medial bones in the left side, sir, orbital side, and soft tissue density seen in the frontal sinus as well here. Next image, sir. Coronal images showing bony erosion of the left orbital roof with soft tissue density lesion in the left frontal sinus extending into the orbit, sir. There is no invasion into the brain, sir. No other bony erosions are noted. Visualized maxillary sinus and right frontal sinus appears normal. That's it, sir. With the above images, sir, is there any history of trauma, sir? If there is any trauma, then
No history
can
of
be a
trauma.
blowout fracture, sir. Okay, sir. With the above history, then my first primary differential would be acute fungal sinusitis, sir. And since there is an suspicious filling defect in the left MCA, I would ask for CT brain and any history of weakness also, sir.
Okay. So acute fungal sinusitis. Any other differentials?
Second differential should be any malignant cause, sir.
Okay.
Such as
Okay.
adenosarcoma lymphoma, sir. Then
Okay. In the sinus.
yes, sir.
Okay, I'm going to show you one more image. Okay, it's
Okay,
just
sir.
that it's not going to add. It's going to add one more image which I did not send to you, but this is the image.
Sagittal sections. So
Sagittal section showing what?
superior rectus appears thickened, sir.
Okay.
And the frontal sinus, there's a
Okay, but
lesion
it is showing the
extending
same
from the
feeling,
front.
opacification
Yes,
of
sir.
the sinus
Yes, sir. Yes, sir.
and the erosions which you described previously.
Yes,
Okay,
sir.
fine. Let's
Yes,
go
sir.
back and look at each and every point you asked for. The MCA is just based on one image, just to say that MCA uploaded is a little tough. Okay, it is just that it is just to convey to you that what we are dealing with is a post-contrast scan.
Post-contrast.
Okay,
Yes.
so that is the important thing which you should observe. It's a post-contrast scan, and this is, don't worry about this. It's just one image. The patient doesn't have any neurological deficit. So patient has got something which is opacifying the left frontal sinus, right?
Yes,
And it
yes,
is
sir.
showing, as you said, erosion, but the better word would have been scalloping, and maybe little erosions, but scalloping and widening of the bony margins of the frontal sinus. Okay.
Okay, sir.
And you said there is erosion or defect which is in infiltration and going into the orbit. So this is perfect. The description now is fine. Now you said the first thought could be acute fungal sinusitis. Now, fungal sinusitis, what is the common cause of fungal sinusitis? Fungal infection is usually related to?
Immunocompromised status, sir.
Usually related to allergy.
Yes, sir.
Yeah, not necessarily. See, the sinus fungus is something different. It can be related to immunocompromised status, but commonly it need not be. The commonly seen fungal sinusitis, which we report every day, is not associated with immunocompromised status, but it is associated with allergy.
Yes, sir.
So if there is an allergy, it doesn't involve a single sinus.
Yes, sir.
Correct?
Yes, sir.
Allergy is a universal phenomenon. So you tend to have inflammation in all sinuses. But here we have a lesion which is only involving the left frontal sinus.
Yes, sir.
Okay. So you have to think before saying whether this is, and you could ask, sir, you are provided the post-contrast scans, is the lesion is enhancing? Okay, so I then give you the plain film. So you have to really measure the ounce field unit on the plain film and post-contrast scans and to identify and tell me, I should have given to you that. But you could have asked me that, sir, please tell me whether this patient is enhancing. But from the lesion which was given to you, like these images, the lesion does not show significant enhancement following contrast, correct?
Yes, sir.
It does not show. It does not
Yes,
show.
sir. Yes.
It does not show. It does not show significant enhancement. As you can see here, compared with the left frontal sinus, the tissue is there. Some artifacts are there because of density changes, but there is no significant enhancements which I can give it to you. So there is a not poorly enhancing or not so enhancing lesion which is eroding. Again, sinusitis is possible. As you said, fungal sinusitis can erode the bone, but the involvement of a single sinus is less likely. So any other malignant cause, you said correctly, yes, it is a malignant causes can erode. Yes, you said carcinoma and lymphoma are two differentials. Any other slightly more common condition which can erode, scallop the margins and then slowly erode the bone in relation to a sinus. Any other disease you know of? Say the drainage of the sinus is not good, what will happen? If the drainage of the sinus is, say, obstructed or not good, what will happen to that sinus?
Mucocele formation, sir.
Exactly. So the mucus will accumulate and it cannot drain. So slowly it expands. So this is called mucocele. The mucocele can expand, scallop the margins, and then slowly deform and then erode the bone. And it can, once it is eroded, it can go into the weak areas. And one of the weak areas in relation to the frontal sinus is the orbital roof. This is a very thin plate, so it can go into the orbit. Okay, so frontal sinus mucocele is one important and probably the first differential you should have thought of. Okay, so remember that unilateral, just a single sinus involvement. All right, so that's an important thing. Right, so you can see that erosion here, and you can see the posterior and anterior walls are entered. And you said the word about if there is a history of trauma, I would think about blowout. Okay, yes, the blowout is a word. I just want to correct that because blowout is a word which is used for two types of fractures around the orbit. One is orbital floor. Okay, so orbital floor blowout, which so the roof fractures are called as roof fractures. No one uses the word blowout for roof fractures. Okay. So one is the floor of the fracture, the other one is the medial lamina papyracea fracture, also known as the medial blowout. Okay. So again, it doesn't look like a trauma. This type of defect is almost like a surgical knife type of defect, and it's usually caused by a slow and smooth erosions, usually caused by slow growing lesions such as mucocele. Okay. So this is the diagnosis, mucocele of frontal sinus. And what are the differential diagnosis here is something which you need to think about. Wherever necrotizing sinonasal lesions is a differential. You said fungal sinusitis, it can be invasive, rhinoscleroma, tuberculosis, leishmaniasis, and syphilis. These are all can cause septal erosions. Okay, vasculitis, weakness, midline granulomas. You already said that about lymphoma and carcinomas. Post-surgical, cocaine can cause midline nasal septal defect, but the mucocele can arise in any part of the sinus. It can lead to smooth and expansile erosion. So the key here is the description. When you see a non-enhancing lesion filling the sinus, which is smoothly widening, eroding, and deforming, then you should think about mucocele of frontal sinus. Okay.
Okay.
So today I'm going to give you a homework. You read all about the mucosals of the sinuses.
Sure.
Okay. There are all the sinuses has got different way of behaving. The sphenoid sinus, sphenoethmoidal rhesus, the ethmoid sinus mucosals, frontal sinus, maxillary sinus mucosals. They all behave differently. And there is also another mucosal in relation to the lacrimal sac mucosal. Okay, there is a congenital nasolacrimal duct obstruction which can present as mucosal. There is also sometimes an acquired lesion which can lead to mucosal formation at the medial aspect of orbit. So these are the mucosals which are commonly kept in the exams, not only in our MD or DMD exams, but also in our also of FRCR as well as American board exams. These lesions are commonly kept.
Okay.
Okay. Thank you, Gogul.
Thank you,
Thank
sir.
you for being with us today, and excellent. Thanks very much.
Thank you, sir.
Thank you.
Thank you,
very
Dr.
much.
Gogul.
Murali?
Yes, sir. Thank you, Dr. Gogul. So for case number 5,
Last
we
case.
have Dr. Krishnan. Yes, sir. From again from Stanley Medical College, sir. So yes, this one you'll have to finish it
Right.
quickly, sir.
Starting
Quickly,
from Stanley, ending from Stanley.
yes, sir.
Oh, yes. Okay. We'll finish it in 1 minute. Very quickly. Okay, Krishnan, are you ready?
Yes, sir.
Okay, Krishnan. Right. Let me just give 1 minute. It's 1 minute to you, 1 minute for me, and 1 minute for discussion. We will finish it up in 3 minutes.
Okay, sir.
Okay. Just waiting for it to move. It's a bit slow.
Okay, sir.
Okay. Now, CT neck of 40-year-old. So I've given you 2 arrow marks to describe. This is you go ahead now.
Okay, sir. 40-year-old patient. The sex of the patient is not provided. CCT axial sections of neck at the level of thyroid and hyoid cartilage. It is showing a well-defined heterogeneously enhancing lesion noted in the right piriform sinus with erosion of right hyoid cartilage and suspicious erosion of right thyroid cartilage, leading to an extralaryngeal involvement of the lesion. The lesion is also causing thickening of right array epiglottic fold and involvement of right vallicula. The right vocal cord appears to be normal. There is no the fat plane between the lesion and vessels of the major vessels of the neck is maintained. No obvious lymphadenopathy noted in the visualized sections, and air-filled cystic lesion, noted in the left side with both intralaryngeal and extralaryngeal component, which is suggestive of a mixed laryngocele. So my primary diagnosis will be supraglottic.
Okay, just hold on. Okay, this is the other 2 images.
Yes, sir.
Did you see this?
Yes, sir. Yes, sir.
Yeah. Okay, now I want you to comment that I wanted to give you 2 things here. I didn't give you the plain CT, so I directly gave you the contrast CT.
Yes, sir.
All right. And the lesion which you described previously, the low attenuating, you said it's heterogeneously enhancing, but it is actually not enhancing. We measured the Ounce-Williams pre and post contrast, and looks there is a slight density difference because of the background. You can see the whole. This was changed density to show the air-filled lesion, which you correctly picked up on the left side. But actually, there is no enhancement within the right-sided lesion. Okay.
Okay,
It
sir.
remains low attenuation, close to fluid attenuation. So there is no enhancement. And the other thing, which is I have not provided the entire images to you, so it's not fair, but your interpretation, I would accept that. But there is actually no bone erosion on the other images. So we got a lesion which is sort of fluid attenuation on the right side in the supraglottic region, but there is no erosion there. Okay, so that I wanted to give you. So before you give the differential, you probably have to redo your differential. Go on now.
Sir, supraglottic tumor with evidence.
So what was your thought? Okay, you already thought about. Okay,
sir, my primary diagnosis was supraglottic tumor with extralaryngeal extension with erosion of hyoid bone.
Okay, so now if the hyoid is normal and the lesion is not showing extension, what will be your differential?
Then it can be laryngocele itself and the right side also, sir. Fluid
But
filled
why it is of fluid
laryngocele.
attenuation?
Fluid
Okay,
filled
fluid filled laryngocele.
laryngocele.
So yes, okay, that's fully acceptable. Yes, that is the most likely cause of appearance there without erosion of bones, which is sort of coming through the thyrohyoid membrane, which is sort of displaced and it is sort of coming out. And so you got a what looks like laryngeal mucocele. It is called laryngeal mucocele, a laryngeal fluid filled laryngocele on the right side, and you got an air filled laryngeal laryngocele on the left side. And on this image, which I am showing to you on your left hand side, do you see anything abnormally enhancement anywhere along the larynx?
Yes, sir.
What is it? Do you think that there is actually a nodular lesion which is protruding? Yeah, it's probably still at supraglottis, maybe at the pseudocord level. Okay, it's not gone to the cord. The cord level is the next image. You can see the arytenoid cartilage, which is located on your right hand side image, and that is the level of true vocal cord. All right, but on the left side, it's just above it, probably at the false vocal cord or most inferior aspect of the supraglottis. But you are actually seeing an enhancing lesion on the right side, correct?
Yes, sir.
Because you can see the lumen is distorted and you can see obvious enhancement on the right side compared to the left side. Then why did you say there is no enhancing lesion? What did you thought of this? Because I gave you only 4 images. What did you thought of this on the right side?
Sir, I thought the whole right piriform sinus is involved in the growth. So I thought this is a heterogeneously enhancing lesion in the right piriform sinus.
Okay. So the whole thing you thought it was a lesion, including the cystic component. Okay, fine, yes, fair enough. So now so what is your thought now? So now you got a laryngeal mucocele on the right side, laryngocele on the left side, enhancing lesion on the right side. What will be your thought?
Supraglottic.
What will be your diagnosis?
Vocal cord growth.
Okay, excellent. Okay, yes, you still have to suspect vocal cord growth because of this enhancement and nodularity. Okay, so now I'm going to ask you one question. That's the diagnosis. You got it very well. Excellent. Supraglottic tumor. So what are the differential diagnoses of enhancing lesion or hyperdense lesion in glottis? Or larynx, for that matter? Apart from the usual laryngeal cancer which we just diagnosed. Come on, quickly.
Thyroclosal duct cyst.
I will ask Amarnath to give you a home and give some sort of a punishment for saying this. I'm asking about enhancing or hyperdense lesions. Which thyroglossal duct cyst in the glottis is going to have a hyperdensity or enhancement?
Sir, papillomas.
Come on, enhancing lesion. Papillomas, yes, common things are common. Papillomas first. Second. Second, come on. You have to say a few things which can enhance the glottis. Okay, papilloma is a really good thought. Yes, squamous papillomas are benign tumors which can enhance. It can be nodular. Okay, the fibroepithelial polyp is other thing which sometimes show enhancement, sometimes show very mild enhancement. Fibroepithelial polyp. Laryngeal cyst does not enhance. Okay, but only when it is complicated. You could have said complicated thyroglossal cyst with supraglottic extension. That's a fair enough thought. But a laryngeal cyst alone can occur because there is a mucous retention cyst can occur within the larynx, but only when it is complicated by either infection or some sort of a hemorrhage. It can look a little bit hyperdense. Hemangiomas spelling is not normal. Hemangiomas in children can occur. Schwannomas, neurofibromas, and neuroectodermal tumors can also occur in larynx. Okay, larynx is not only a place. See, larynx has got an epithelium, it has got a mesenchyme, it has got a cartilage, it has got a bone. So you have to think about all lesions, which it's a small structure, but we always tend to think papillomas and carcinomas, which are the most common lesions. small vocal nodule. All these are the common ones, but the unusual rare one list is many, and you can have so many different type of. So you can see all the mesenchymal tumors, nerve sheath tumors, carcinomas, rhabdomyomas, granulomatous lesions like tuberculosis, sarcoid, Weakness, granulomatous. These are all can have nodules in the larynx. Lymphomas can involve there. So there's a differential diagnosis of enhancing lesion in the glottis is many. So, but although the commonest is carcinoma, in your exam or in your practice, sometimes we get stuck with certain lesions which can be of different origin. All right.
Okay.
Okay. And of course, chondromatous lesions. You can have chondromas, chondrosarcomas of the larynx, which has been reported as well. Okay, this list is not complete, and there are several other lesions. Okay, excellent, Krishnan, for making the diagnosis. You correctly interpreted that as a laryngeal mucocele, and you came out with the good, because whenever there is an internal or external laryngocele, you got to think of, you cannot just exclude this is at a benign appearance, but we have to always make an effort to exclude a surface lesion, because it is the surface lesion which is blocking the laryngeal ventricle on the laryngeal side, and therefore increases the pressure inside the laryngeal ventricle, and slowly it expands from a laryngocele. So laryngocele can be a presentation of a laryngeal carcinoma. So that is the key learning point in this case.
Okay.
All right.
Okay.
Thank you very much, Krishna, and all the best to all the residents who are going to take the exam. Murali, I think thank you very much to all the professors who have taught these students. I think they have done an excellent job.
Thank you
and
so
the
much, sir.
teachers, not only professors, associate. All right. Am I done?
You're done, sir. Thank you so much to spare your Sunday. Yes, sir.
Thank you, Murali.
Yes, Dr.
Yes.
Varaprasad is here.
Time
for
to
the
go
next
to
Yeah,
sleep.
Murali, good morning. Are you able to hear me?
Yes,
Bye
sir,
bye.
we can hear you clearly, sir.
Okay,
But
Murali.
I think Dr. Vara is ready.
Yes.
Ambarasu,
So-
you are always in action.
Hi.
I'm sharing the
Hi,
screen.
Vara. All the best.
We
Log
can
out
see
now.
you, sir. Yeah, you can see your screen.
Okay, thanks.
Thank you, sir. Bye, sir.
Right?
Bye.
Is it right?
Yes, sir. We can see it, sir. Yes, sir. So we have Dr. Rosh with us, sir. Dr. Rosh is from CMC Vellore. So
Okay.
he'll be discussing the first case with you, sir.
Okay.
Dr.
I shared the
Raj?
screen.
Good
Can
morning.
I see the student
Good
here?
morning.
We can hear you.
Good morning, sir.
Murali, can I able to see the student?
Yes, you are able to see, sir. Down to
Good morning, sir.
No, when I'm sharing, I'm not seeing the student.
sir. Click hide, sir.
Yes. But again, I have to share, right?
Yeah, you have to share the screen. You can see the student now.
Here is my slides. No, when I'm sharing, it's going off.
Okay, sir. I guess you have to hear him only.
Okay.
Yeah.
Right. Good morning. Shall we
morning,
start?
sir. Yes, sir. Sure.
See, that's an excellent session with Dr. Ambarasu, and you are going to have next Dr. Rajgopal after me, and excellent panel of teachers. I'm very happy to be invited, and in between these two legends of Dr. Ambarasu and Dr. Rajgopal, and we'll straight away start this. And I always show this to every student when we are going for an exam. Okay. So this is the most important aspect. So this remains constant always. So whenever you are describing a lesion, so try to do this approach. Pick up the finding and describe it, and discuss each important subcomponent of the findings, and narrate into 2 or 3 differential diagnoses, and finally come to your diagnosis. In between these two, try to see that what is the appropriate investigation or further investigation, what else you want to do to conclude a final diagnosis. This is what I usually teach my residents. So your first case, start describing.
Good morning, sir. I have been provided with plain radiographs, AP view and lateral view of the left elbow joint, including the adjacent arm and forearm of an individual with mature skeleton. there is a lesion noted in the which is centrally located in the metadiaphysis of the left distal humerus. It is mildly expansile lytic lesion. There is no matrix mineralization. It is well-defined, well-marginated lesion with narrow zone of transition. There is mild endosteal scalloping of the lesion. There is no cortical destruction. There is a mild cortical thickening or solid continuous periosteal reaction. There is no significant soft tissue component associated with the lesion. There are no obvious fractures. There is no lesion in the rest of the visualized skeleton. The elbow joint is unremarkable.
Okay.
So summarizing
what
the
you are thinking
findings.
on this? Okay, let me interrupt here. Here, there is no periosteal reaction. Okay, maybe very, very subtle here, but the cortical thickness is perfect. The second important component which you missed is this is the soft tissue component, right?
Okay, sir.
You able to see this?
Yes, sir. I noticed that one. I was not very sure what
see,
to.
because this is a part. You see, suddenly there is something which is happening here, and again, the muscle flames are very clear, right? So this is the soft tissue component. Okay. If you are doubt, you can say there is a doubtful soft tissue component. You are always, it may or may not. You can take on either way if after seeing the next film, right? So don't say there is no soft tissue component, especially when there is a suspicious one. Okay. Joint is normal and everything is normal. So where do you put this particular lesion among this? Is it congenital, traumatic, infection, or tumor?
I would like to place it in tumor, sir.
Excellent. So what are the tumors? So you described the findings, fantastic. And now discuss about this. So where do you get cortical thickening? Where do you get endosteal scalloping? Where do you get a lytic lesion like this? Why there is a narrow transitional zone? And if the narrow transitional zone, what is your differential diagnosis based on these findings?
Sir, I was thinking mostly in terms of a lytic non-aggressive lesion without a soft tissue component. And my differentials in that case were like fibrous dysplasia, enchondroma, possibly solitary unicameral bone cyst. Given the soft tissue component, I would also like to consider possibility of Ewing sarcoma, lytic lesion with a large soft tissue component.
So in of these findings, which tumor shows cortical thickening? You said cortical thickening, right?
Yes,
ABC, enchondroma, and all those things are going to have cortical thickening along the scalloping?
No, sir. So, they don't have.
So those are excluded, right?
Okay, sir. Then I would be more inclined to give a differential of Ewing sarcoma.
Okay. What you are going to get Ewing sarcoma?
Classically described is a lamellated periosteal reaction, large soft tissue component. Zone of transition can be wide. There can be skeletal metastasis, skip lesions, bone metastasis, bone-to-bone metastasis. Diaphyseal location. So
you can also
in
exclude
this case,
some of these conditions by looking at the history of pain, right? When there is no fracture, simple bone cyst will not give pain. When there is no fracture, enchondromas will not give pain. Some of the lesions which can exclude by looking at this history of pain. Okay, Ewing sarcoma can give some sort of pain. So you can exclude some of the things looking at the pain, some of the lesions looking at the age, some of the lesions looking at the location, and some of the lesions looking at the features of the lesion. So basically, we have a lesion which is lytic and definitely having a relatively narrow zone of transition. And it's a long-standing lesion says that there is a scalloping and also there is a cortical thickening. No obvious periosteal reaction, maybe very subtle here, but no obvious periosteal reaction, and there is a suspicious lesion, a soft tissue component. And so you are considering tumor. So what else you want? I would like to show and give an attention here. Whenever you see any particular lesion that is traumatic or neoplastic, the best way to pick up the cortical erosions and the cortical fractures, etc., is take your cursor as a pencil
He's not
Murali, able to hear me? Hello?
We are able to hear you, sir.
I'll inform.
Okay. Okay. The best way to see this is drag down the cursor or a pencil along the cortices. You try to see this same along the cortices. When you come here, there is a little bit of lucency here, right? Probably there is a suspicion of cortical breach here. That's so you need to pick up the cortical breaks and the cortical lucencies or whatever it is.
I think somebody else have the mic on. Can you put off your mic? Either one of the students who have joined.
Yeah,
or...
there. Take a left there and then a right.
I think it's stop. Sir, Rajagopal, sir. Okay, sir. Proceed, sir.
Yes.
Okay. What else you want now? So
Sir,
you're able to
given the
identify this,
possibility
right?
that, yes, sir. Given the possibility that is a bone tumor, I would like to further evaluate with bone scan to look for any bone-to-bone metastasis, MRI to look for local extension of the tumor, neurovascular bundle involvement, any possibility of joint involvement, and also CT thorax or chest X-ray or a CT thorax to look for any lung metastasis.
Okay. I will give you
Yeah.
next film.
Yeah.
It is
From Baking, you
MRI.
take a left. Left
Describe
and
this
then a
one.
right.
Start describing.
Yes.
I've been provided with multiple MR images showing. So one is a fat saturated image, a STIR or PD fat sat, showing the lesion is involving the marrow, the hyperintensity involving the marrow, and there is.
Yes. Take a right there.
Yeah, you carry on. Ignore that background music.
To extend over the part.
Come on, you can see blue building on the right.
Into the soft tissue component, which is also T2 hyperintense. The extent of the lesion is clearly identified on the T1 weighted image, which is seen to involve the marrow in the diaphysis meta and reaching almost up to the epiphysis. There's no obvious joint extension.
Okay.
Then not able to identify any neurovascular structures on the provided images.
Okay. This is the next set. So axial images are the best images to assess for the compartmentalization of the lesion and also the involvement of the neurovascular bundles. Never ever say in sagittal and coronal images. Okay, they misguide you because the plane they go in this plane or in this plane or in this plane. So you may miss this. So always to say that neurovascular involvement and compartmentalization of the lesion on axial images. Next, come on, describe this. The lesion is hyperintense on T2 and involving that you
the.
already described. See, don't
Yes,
repeat the findings which you already described. What extra information you are getting from these images to here? That's enough. You say there is no neurovascular bundle involvement. That's fantastic. And what you're able to see in extra is more clear, confident there is a complication between these two lesions.
Yes,
right?
sir. Yes, sir.
Yes. What is this next?
Cortical breach and there is extension into the soft tissue. The soft tissue seems to be a centrally hypointense lesion.
So what you are thinking now, based on these findings?
Possibility of an infection.
Yes. So you are diagnosed from tumor to the infection. So always try to include infection in your different diagnosis, especially when you see this, cortical thickening, and especially when you see a soft tissue component. That should be there in a differential diagnosis when reading a brain radiograph. Though it appears apparently like a tumor, but chronic infections without chronic infections with cortical thickening will give a differential diagnosis on brain radiograph. That infection has to be included. Okay, this is near fluid signal intensity in the medullary lesion with the cortical thickening and a lot of soft tissue abscesses. So, what is the final diagnosis?
Chronic osteomyelitis.
Yes, with intramedullary abscess and then a soft tissue abscess. So these are the things which you have to see. Sometimes you see this, sometimes periosteal reaction walks like onion peel, etc. may be absent. You just see sclerosis. It looks like a sclerotic dysplasia or some sclerosing tumor. But what happens to see once you go and have the next investigations, you have to keep these minds to say that this is infection. Elongated shape, facial edema, soft tissue edema, subperiosteal fluids, and sinus tract. See, for example, the same case here. This is the MR. See what the clinical sign which you are going to see in this. What is the sign?
Penumbra.
Excellent. Once you see this type of thing, you are very confident that this is an osteomyelitis. So see extensive soft tissue edema, extensive medullary edema with fluid signals within. This elongated lesion with the sinus tracts like this and soft tissue abscesses, and sometimes a subperiosteal abscess like this. This is another case with the chronic osteomyelitis, cortical thickening and intramedullary, and subperiosteal abscesses like this. So these are the things which you are supposed to answer, and they may give a companion cases like this and try to identify the extra findings. This is how you need to differentiate this between the malignancy. Osteosarcoma is also looking like the long lesions. They'll have osteoid, necrosis, etc. But they usually don't produce this type of soft tissues edemas. And this sign is absent, and this soft tissue fluid collections and sinus tracts will be absent in osteosarcoma. So always see that whenever there is a possibility that an equivocal lesion. And the teaching point in this particular case, which I want to show you again and again, is see, this is the area of this cortical breach. So try to see the cortex, not only the outer surface and also the inner surface. Inner surface, you identify the endosteal scalloping and brought your pencil or pen here. Suddenly you can see this endosteal scalloping is more and cortical thinning is more. And also this side is also cortical thinning is more. So this, and if you see this, there is something like a buttonhole here. So that's how you have to identify there may be a cortical breach here and a soft tissue component here. This subtle finding marker, you need to identify. Yes, you rightly said Ewing sarcomas can have it, but Ewing sarcomas can have will not have the cortical thickening like this. They will have sulfurization more along with the periosteal reactions. So nicely done. Keep this in mind, how to differentiate between your exercises, differentiate how to between infections and malignancies, especially in a long lesion, and what are the osteomyelitis, various types of osteomyelitis, what are the subtle markers of chronic osteomyelitis, and also what are the MRI findings, and how to differentiate between a long lesions like long osteosarcoma. Right, well done. Murali, next.
Thank you, sir.
Yes, sir. Thank you, Dr. Raj.
Thank you, sir.
So before the next joins, you can see sometimes you have chronic osteomyelitis like this, both bones are involved. Try to see the both bones. When the both bones are involved, like let's say it will be malignant, and you see the same principle, soft tissue edemas, fluids, etc. And this is the chronic venous ulcer, chronic osteomyelitis, sometimes subtle osteomyelitis like this in calcaneum. Because of lot of edema, you need to pick up this. And there is a chance that it could be differential diagnosis of chondroblastoma. This is proved as chondritis. In pediatrics, it should be very useful. You try to see the metaphysis and then also the involvement of the epiphysis. Once the epiphysis is involved, there is also a chance that this may go into the joint and produce septic arthritis. And see for this small abscesses. Okay, case 2.
Yes, sir.
Good morning.
We have this is Dr. Pon Shankar, sir. He's from Stanley Medical College. He's discussing
Hi.
case 2.
Good morning, sir. Good morning,
Stanley guys to teach is very tough. They are very brilliant. Come on.
Sir, my case is a 62-year-old male who has come with complaints of swelling in the thumb of the left hand for the past 2 months, and I have been provided with the PA and lateral images of hand of the same patient, and it shows a well-defined expansile lytic lesion noted in the distal phalanx of the thumb, and the lesion here shows it's a central in location, and it has caused endosteal scalloping, and there is no specific matrix, and there is no periosteal reaction. There is some soft tissue component is there, and so to conclude, there is a well-defined centrally placed expansile lytic lesion with soft tissue component, and there is no periosteal reaction, and there is endosteal scalloping noted in the distal phalanx of the first finger, that is the thumb, and the joint cavity appears to be normal, and there is no other lesion noted in the rest of the fingers or in the metacarpals, and so my differential diagnosis would include, first is the glomus tumor. So to confirm, I would like to do ultrasound of the same patient to look for any vascularity, so that if there is intense vascularity on color Doppler, glomus tumor can be picked up. And the second differential diagnosis it include the epidermal inclusion cyst. To that, I have to ask the history of any trauma there. And the third differential diagnosis could be an enchondroma. And to further characterize the lesion, I would like to further investigate with the MRI also. And the last differential diagnosis could be, it can be an GCT also, sir, or it can be a very rare possibility of intraosseous ganglion also could be there. So further, I would like to do ultrasound with Doppler for the patient, and to further characterize the patient with MRI, sir.
Yeah, that's fantastic and phenomenal. Whenever you see a tumor, or tumor is the first possibility in your mind whenever a lesion, and try to describe it in the format of stamps. I used to teach many times. That is site, transitional zone, age, aggressiveness, matrix, periosteal reaction, soft tissue component. You perfectly described here. There's a lytic lesion which is obviously a little bit expansile, and there's a soft tissue component.
Yes,
and yes, this is having a little bit of endosteal scalloping and also cortical breaches.
Yes, sir.
So your first diagnosis of glomus tumor is a bony tumor or soft tissue tumor?
Sir, it's a soft tissue tumor, sir, but intraosseous glomus tumor can occur, sir.
How common intraosseous glomus tumor is?
Sir, it's very rare, sir.
If it is an intraosseous glomus tumor, your Doppler are going to work on that?
So there is some soft tissue component is also there. So with that window, we can try to get, sir, elicit the findings.
Okay, your explanation is valid, but intraosseous glomus tumors are very, very, very rare.
Okay,
and
sir.
to try to do the common things on this. Rest of all your differential diagnosis I accept. In fact,
Yes,
I also thought in the same line. Okay.
Okay, sir.
Excellent. And so what else you want? You want a Doppler? I didn't do a Doppler in this case. I have
Okay,
an MR. You just go through that.
Sir, selected coronal images of the hand with the thumb shows stir, and T1 and T2 images have been provided, which shows stir hyperintense lesion with some soft tissue component noted in the distal phalanx, and the interphalangeal joint appears to be normal, and it is T1 hypointense, and it is T2 hyperintense also, sir. So I need it should be a contrast images further, sir, for enhancement pattern.
I don't have a contrast, but I have an extension of these axial images with a diffusion weighted image.
So the diffusion weighted images, it shows restricted diffusion. So this can lead to a diagnosis of epidermal inclusion cysts, sir.
Great. So what you have to say is, once your MRI is shown, you
Yes,
substantiate all your plane radiograph findings, and also
Okay,
say you are evident about the soft tissue
component. Yes, sir.
Also say that whether it's extending to the joint or not, and
Yes, sir.
also see this what about the adjacent tendons. Okay.
Okay, sir.
Okay,
Okay,
or whether they are torn or whether they involved or infiltrated, or these arising from the tendon sheath and eroding the bone, etc., we need to identify. That is the advantage of MRI, right?
Yes,
You have to
sir.
substantiate whatever your findings on plane radiograph on MR. Yes, these are the findings which are correlating with MR. This is the signal intensity. It is not extending to the joint. You have soft tissue component. The tendons are normal and other bones are normal. You have to also to see the other bones for subtle multiple findings, because here the age is 62 years, right? Always there may be a small foracial metastasis, which is very, very rare, but you have to take in the differential diagnosis. I also thought in the same line of view, it could be an epidermal inclusion cyst, or giant cell reparative granuloma, or tumor. I excluded glomus because it's an osseous tumor, which is very, very rare. And
Okay, sir.
based on the diffusion, I gave the first diagnosis of epidermal inclusion cyst.
Yes, sir.
Epidermal inclusion cyst.
Okay,
With
sir.
erosion. Okay. Very, very old history of trauma. That was very subtle and not very at the age of 62 years, to get the history is not very
Yes, sir.
easy, but very, very subtle trauma. And
Okay,
you're
sir.
right, it is an epidermal inclusion cyst. I will show some companion cases on this. What is this? This is the typical finding, right? The epidermal
Yes, sir.
inclusion cyst. Usually, you see like this, one side, and there will be a cortical breach with a
Cortical
slit
breach.
and a little bit soft tissue component. Okay.
Yes, sir.
This is a typical epidermal inclusion
Epidermal
cyst.
inclusion.
Yes. Next. What is this? Like another companion case, which is having the same principles which I showed in the first case.
Sir, there is
A tumor-looking lesion. Once you have a lot of soft tissue edema,
yes,
and something is going like a fluid-like thing like this. Always, what it could be?
enchondroma, you can think of, sir.
First case, what I told you.
Sir.
Enchondromas will not have facial edemas like this, right?
Yes, sir.
And the fluid edema of layer.
Infection, sir.
This is an infection.
Infection, sir.
Okay. What about this? What about this? Another case.
This can be a dactylitis, sir. Tubercular cause or non-specific dactylitis. Infection.
Yeah, that is one of the possibilities of this. You just try to keep on that. But small, multiple bubbly cystic areas within the bone says that it's an intraosseous hemangiomatous lesion or cystic hemangiomas with a soft tissue component.
Okay.
When you have these two together, this could be a soft tissue and intraosseous hemangioma. That is the most important you have to keep in mind. That's how it was proved also.
Yes, sir.
Next case. This is your fancy diagnosis and commonly put in exams. This is typical of
enchondroma, sir.
Enchondroma. And this is a case with enchondroma pathological
with malignant transformation.
And you always remember that whenever if you have a serial radiograph between these and this is not the same patient, but if you have a serial radiographs like this, if this cortical thickness thins out more than 50% within 6 months, I always try to consider a low-grade chondrosarcoma. And also if there is a pathological fracture at the time of presentation, always try to keep your low-grade chondrosarcoma into the picture. What is this? These are radial lesions. So these lesions, to put is these are eccentric, lytic, and also like a lot of soft component. These also, if you say differential diagnosis, most of the times you are right, and they will accept this. This case is unfortunate case to prove tuberculosis, but not typical case of a tuberculosis presentation.
Okay, sir.
Okay, all these things you rightly pointed. Excellent. I think we'll go to the case 3, Murli.
Yes, sir.
Thank you, sir. Thank you, sir. Thank you so much, sir.
Thank you, Podshankar.
Thank you, sir.
We have Dr. Nibia, sir. Next. Dr. Nivya, are you online? Yeah, okay. Yeah.
Yes, sir. Can you hear me, sir?
Yeah, we can hear you. Dr. Nivya is from Sri Ramchandra University, sir.
Yeah.
Good afternoon, sir. It's an X-ray humerus AP view of a 48-year-old male patient, which shows well-defined, mildly expansile lytic lesion noted in the diaphyseal region, with no sclerotic margin, and it is seen to involve the medullary and the cortical regions, and there is narrow zone of transition, and there is no obvious matrix noted, and the cortex, it appears to be slightly eroded in the form of there is thinning and irregularity noted.
Yes, correct, perfect.
And there is mild periosteal reaction, but it looks like solid periosteal reaction noted on the lateral aspect of the humerus, a little above the lytic lesion. And there is mild soft tissue component seen on either side, but there is no obvious calcification or anything noted in the soft tissue.
So your Stamp's description is perfect. So you say this is tumor. Okay.
Yes, sir. So
what is your differential diagnosis?
Differentials I would like for this age group and in the diaphyseal region with a mild aggressive type of tumor. I would like to give the differential of first differential would be metastasis.
Okay.
And my second differential will be either lymphoma or solitary plasmacytoma.
Okay.
And third, I'll go for it can be either even some infection like osteomyelitis, mild aggressive looking can occur in that also. And I would like to keep the last differential as osteosarcoma, because there is in osteosarcoma there will be more aggressive periosteal reaction and soft tissue involvement, which is not much seen in this. So I will keep it as the last DD, sir.
This age group described with the classical teaching of MML, metastasis, myeloma, lymphoma is perfect. But is the dislocation here? Metaphysis or diaphysis is the common location among these two?
Sir?
Metastasis, myeloma, lymphoma after age of 40 years, are they common in metaphyseal location or diaphyseal location?
Metastasis diaphysis can occur, is most common, sir. But for lymphoma, long bones, metadiaphyseal involvement can be seen, sir.
Yeah, this is a diaphyseal, right? Most often they are metaphysis and metadiaphyseal region. This is a diaphysis. This can occur here also, but this is not a regular routine sequence for metastasis, myeloma, and lymphoma after the age of 40 years. The standard teaching protocol. So what else you want to confirm? See the single lesion, okay, right?
It's a solitary lesion.
Single lesion. So among these metastasis, myeloma, lymphoma, which you're going to put? If the bones are abnormal, the bone is not abnormal, right? And you can always, though I didn't have.
So?
Yes, so it may not be a myeloma, right?
Yes, sir. Rest of the bone appears, density appears to be normal.
Yeah,
and there
still
is no...
metastasis and your lymphoma, etc., are there. So I'm going to give you an next set, and always ask the examiner the lateral view. Don't ever conclude on the plane radiograph of at the end. You describe, at the end you ask the lateral radiograph. Unfortunately, in this patient I didn't get the lateral radiograph. This came for a second opinion to me 2 days back, so I kept this case. I don't have the lateral radiograph. That is the reason all these artifacts are there in this. So I will give you the MR. Now you say.
It's MR, we can see well-defined T2 hyperintense and T1 hypointense lesion.
Okay.
Yeah. Noted in the medullary region in the diaphysis of the humerus.
Yes.
And there is a skip lesion noted separately below the lesion also, so below the primary lesion.
Good.
Similar lesion, and there is cortical thinning, but in this
Good.
there is no obvious soft tissue involvement is seen, sir. Mild edema, linear strand in the STIR images. I can see a mild soft tissue edema alone is seen.
Perfect on both sides. Okay. Yeah. So I'll give you the next set. This is an axial image. So what do you want? What you're supposed to do in axial images? Any soft tissue component and your edema is okay, perfect. This is a gross cortical thinning here and almost breach here. Okay.
I look for the cortical breach, sir, but there is no obvious cortical breach in this.
Yes.
But there is hypointense areas noted within,
okay,
which may be some calcific or region.
Okay, so based on the signal intensity, now what is your differential diagnosis?
It can be.
Can it be enchondroma? Can it be enchondroma? Can it be a chondrosarcoma?
Chondrosarcoma, we can think, sir, because the size is more than 3 centimeter. Enchondroma, mostly it will be smaller size and ring and arc calcification will be there. The hypointense areas can be some chondrite calcification. So,
okay,
chondrosarcoma, we can think, sir. But there is no periosteal soft tissue involvement or periosteal reaction.
See, this is grossly thinned right here. So you can see this especially. This is a grossly thinned. There is no soft tissue component, but the cortex is grossly thinned here, especially at this point. Okay, just to have a differential diagnosis. So now, what is your first differential diagnosis based on this, and what is your second differential diagnosis? Anything more you want?
I'll go with chondrosarcoma and lymphoma. Can it be lymphoma?
So do you have chondrosarcoma with a skip lesion, lymphoma with a skip lesion?
No, sir. Skip lesion usually occurs with,
okay, your different diagnosis and everything is perfect, but whatever you say, you stick to that. You saw 2 lesions, and what are the lesions which are going to say? Yes, chondrosarcoma is the differential diagnosis, and you consider on your first metastasis, you said. Okay, yes. Metastasis have this possibility, right? Because there are 2 lesions. Okay, your plain radiographic consideration of metastasis, you substantiate with your MR because there are 2 lesions. Is it right? Okay, that can be done, and chondrosarcoma is one of the important possibility here. So what else you want?
I would like to any abdominal ultrasound or anything because it's a male patient.
So I have this for you. What do you see here?
It's a axial CT section, CT axial section showing in the adrenal region there is some soft tissue density lesion, sir, in the right adrenal region.
Excellent.
And,
yes.
It has some surrounding
finding?
fat stranding, so it can be an adrenal tumor with metastasis to the bone. But it's very uncommon for an adrenal tumor for bone mets.
What else you are seeing?
There is some surgery done for the patient. I suggest.
Forget about this. Forget about this. What else you see? See, I kept this purposefully to say that. Okay, what is here? Hey, what is here? See my arrow.
There is okay, sir. There is some vascular metastasis in the liver. Okay, bony metastasis.
Near the pedicle, posterior aspect, a lytic lesion. And now what you are correlating on that? This is the inferior section or a contrast section. So what is your final diagnosis now?
Yes, sir. 1 minute, sir.
Go through, no problem.
Okay. There is the left kidney appears enlarged with heterogeneous parenchymal density. So it can be a renal cell carcinoma which has metastasized to the bone, vertebra, and the
metastasized to vertebral body, opposite adrenal, and also to the humerus. Okay, fantastic. So always consider these lesions, especially in the radiograph, your perfect description, your perfect differential diagnosis, 100% mark for that. On MR, it was a little bit confusing to have a contract signal, but the other lesion shows that this our plain radiographic findings of metastasis are yes, this can be the metastatic lesion. Then we asked for the other investigations. Then these things came into the picture. So till I saw these 3 lesions, my diagnosis are just stand on differential diagnosis of metastasis versus chondrosarcoma and plain radiograph. But chondrosarcoma, a little bit of the single lesion, and after seeing the lesions, I felt that it could be metastasis. And after that, they provided this and said this is the primary malignancy with this. Okay, excellent. Next case, Murali. This is a companion case before next patient, next student joins. Is a 60 years female. Another important aspect here, you can see this, the same age group, cortical thickening here. Yeah, cortical thickening here. Just I'm describing you lesion here. You can see it, altered signal intensity lesion, altered signal intensity lesion with a soft tissue component and showing lot of nuclear medicine. This is also a known case of carcinoma breast and metastasis. Post-treatment, you can see the total disappearance of the lesion. So these age group, especially after the 40 years age group, a lesion which is looking a little bit aggressive, always keep your differential diagnosis of metastasis. Though it be a single lesion. That is the teaching which I want to tell you. Though it is a single lesion, and apparently it may not be a single if you have a total skeletal survey or a nuclear medicine scan. Even if it's a single lesion, you always consider metastasis in this cases. Okay?
Thank you, sir.
Thank you,
Dr. Akash, are you there? Yes.
Yes, sir.
Dr. Akash is from KMC, sir, Kilpauk Medical College.
Yes, Akash, please go through.
Good afternoon, sir. Yes, sir. I have given a case of AP and lateral radiograph of a skeletally mature patient's knee. Shows ill-defined juxta-articular, punched out, eccentric erosions and cortical irregularities of the distal femur and proximal tibia, both on the medial and lateral aspects, with the overhanging edges noted on the medial aspect. There is no evidence of any periarticular osteopenia or joint space narrowing. The joint space seems to be preserved on both the medial and the lateral aspects. There is no evidence of any soft tissue present, soft tissue mass or soft tissue calcification present around it. And there is no evidence of osteophytes. Upper end of fibula seems to be normal. There is also an ill-defined lytic area, subtle ill-defined lytic area noted in the subarticular region of the medial tibial condyle. medial tibial
Okay,
condyle.
this is right. Okay.
Yeah, sir.
Okay.
Yeah.
Agreed.
So with this and the patella seems to be normal. The patellofemoral joint seems to be normal. So with this description, my differential diagnosis will be first differential will be gout, sir. Then after that, other synovial pathology, synovial chondromatosis or pigmented villonodular synovitis, which is causing this erosions due to pressure erosions. Then CPPD, crystal deposition disease. Then other differentials which I can rule out here are osteoarthritis and rheumatoid arthritis, because there are no presence of osteophytes and no joint space narrowing, no osteopenia. So these are the differentials, sir.
So first, after describing the findings, you say that this is a arthritic disorder, right?
Yes.
Once you feel that arthritic disorder, you can always have a question to the examiner or request to the examiner that is it only this joint involved or multiple joints involved? Okay.
Yes, sir.
You can request that. If they are, you can say that it is the only joint involved. My possible differential diagnosis is this, because monoarticular arthritis, polyarticular arthritis, totally different pictures, right?
Yes.
So that is the reason we have to ask this. Or you can say that if even without asking, if this is the only joint involvement, my differential diagnosis are like this. Okay. And your CPPD, etc., mostly they are present with calcifications and cartilage calcifications.
Yes, sir.
Synovial osteochondromatosis is ruled out. Primary synovial osteochondromatosis, what is synovial? Part of the synovial thickening, you will have the osteotic bodies, right? Uniform osteotic bodies within the synovial joint spaces. And if it is secondary synovial osteochondromatosis, you have the osteoarthritis picture. So both are ruled out.
Ruled out.
Okay, gout is a possibility, but still gout is or marginal erosions will be here like this or will be here like this, but still is a gout is a possibility. Another important point which I want to tell you and stress you is if you see the bone from here to here as a gradient, which is bone from here to here as a gradient, the trabecular pattern from here and coming to here, the trabecular pattern is going to be much more prominent on both sides. This gives a clue that is a periarticular osteopenia.
Yes.
Okay. This subtle finding you need to pick up. This is a periarticular osteopenia. Okay. The exposure factors of radiographic quality or etc. may not give a true picture of a proliferate of established periarticular osteopenia always. You try to pick up this. Okay. This is a very, very important aspect. Prominent trabecular pattern as an osteopenia or osteoporosis. Here also the same findings because of adjacent edema, they become prominent appearance, not actually the trabecular being atrophied or destroyed, but because of the edema there, they appears a little bit prominent on the radiographs. So what your possible differential diagnosis now, can it be pyogenic arthritis? Can it be a tuberculous arthritis? These two you missed.
Yes, sir. Since if it is a mono arthritis, yes, sir. To infective will be a differential.
Okay. So I will give you an excerpt.
Yes, sir.
This is an MR. Yeah. Describe.
Yes, coronal, selected coronal and sagittal stir and T1 weighted images, sagittal T1 weighted images. Show
this is T1, this is T2, these two are stir. Yeah, not suppressed.
So the PD fat saturated images show ill-defined hypointense areas in the medial femoral, both medial and lateral femoral condyles, and the lateral tibial condyle in the subarticular region with surrounding hyperintensities indicating edema.
Yes, this is the edema, right? That gives the periarticular osteopenia. Next.
Yes, sir. Then.
So do you have a massive joint effusion?
No, sir. There is no significant joint effusion, sir. There is very maybe mild.
Very minimal joint effusion. But what you see is there is no joint effusion, but there is fullness in the supraclavicular bursa, and there is also the fullness in the posterior capsule because of synovial thickening, right? This is all synovial thickening, right? This is all synovial thickening.
Yes.
This is all synovial thickening. Okay. So this synovial thickening is causing this particular erosion. So now what is your diagnosis?
There's so much of
differential diagnosis based on plain radiograph and this together.
so much annual thickening with a little joint effusion, osteopenia. I may think of rheumatoid arthritis also.
Monoarticular.
Monoarticular infectious, sir, mainly. Pyogenic arthritis.
Okay.
Or
when compared to the radiograph, an MR, the joint space appears more narrowed, right?
yes,
You
sir.
can see the joint space, you don't see that much cartilage and all those things. So typically looking joint space is not this, okay?
Yes.
It appears a bit more narrowing of the joint space. And most important aspect, whenever you see on MR, whenever the synovial thickening, you have to see that what signal intensity the synovium is giving. T2 high intense synovial thickening is a very, very important aspect. Usually when there is inflammation, the synovium will be a bright white, but T2 hypointense synovium is very, very important aspect of few very common diagnosis. Okay, out of that, tuberculosis is the first one.
Tuberculosis.
Okay, so there is another companion case of this.
Yes, sir.
This is a tuberculous synovitis with a large intraosseous erosion. If you go on, there will be rim enhancement, synovial thickening, which is T2 hypointense. You may have pigmented large synovitis also like this, but have a gradient blooming artifacts within the synovium also have a little bit even hyperintensities if there is a blood. You can also say pigmented nodular synovitis in this differential diagnosis. But how to differentiate this? We'll come to a little later. You'll have a lot of soft tissue abscesses. Sometimes it's tuberculous arthritis. You can have if you give a contour, there will be marginal erosions which are enhancing like this. And you can see this is a typical case of tuberculous arthritis. There's a periarticular osteopenia. Though the joint space narrowing in early stage you may not see.
Yes.
Peripherally located erosions like this. These are very, very important, which is known as Phemister style. Examiners may ask this.
Yes, sir.
So this is very important to look out, and you also should always include differential diagnosis of tuberculosis when you see this type of affliction.
Yes, sir.
Okay, this is the stages of tuberculous synovitis, and we need to diagnose in this particular stage. Stage 1 or stage 2. This is stage 2. The case which we showed here is stage 2 tuberculous synovitis. On stage 3, stage 4, it's very, very tough to get back into the normal joint even after treatment. These are companion case. You see, when compared to that, radiograph looking almost normal, but except a little bit more fullness here.
Yes,
but
sir.
on MR, you can see a lot of synovial thickening, a lot of effusion, a lot of synovial thickening. This is also monoarticular joint involvement, but the erosions are much less. Okay, erosions are much less when compared to they are small and much less. This case recently posted in our MSK group with the enhancement around the contrast by Dr. Joe Thomas. This is a worked up case. You can see the synovial proliferation and there is a polyarticular involvement also. So this is a rheumatoid arthritis, very classical case of rheumatoid arthritis. So there is always confusion. Why I keep these cases, go back and read, because they make you a tuberculous arthritis or rheumatoid arthritis or pyogenic arthritis as one of your case. And basically they concentrate on how to differentiate this. And all of you, the residents, try to see this screenshot. This is made by Dr. Ankur Goyal, which is going to come in next IRA textbook of radiology, how to differentiate between tuberculosis, rheumatoid arthritis, and pyogenic arthritis. You can screenshot or print screen this and try to see this, all the findings, clinical presentation, synovial thickening, bone erosions, enhancement at the site of the bone erosion, rim enhancement, like what we saw in a companion case, and joint space occurs last in tuberculosis, early in pyogenic, and rest of the arthritis. Subchondral marrow edema, cystic abscesses, extraarticular soft tissues, periarthritis, joint effusions, and any other associated features like lymphadenopathy, or if it is bursitis, it's rheumatoid arthritis, if it is periosteitis, it is pyogenic arthritis. And this we don't want to see this. The ankylosing, our target is to identify in stage 1 or stage 2. Okay, this is the important slide. So that is the reason I kept this for you. Excellent, you properly done that. It's not so easy to pick up a monoarticular arthritis without proper clinical and biochemical findings. But only thing is, you pick up the findings, you rightly picked up, you rightly set the differential diagnosis. And one important point which I want to tell you is gout is not so common in knee joint. Though if it is at all involves, it involves the patella and adjacent tendons after the foot bones, exercise, especially the great toe. So you don't keep gout as a primary diagnosis.
Yes.
And likewise, you try to see that other arthritis like psoriatic arthritis, whether can this mimic with soft tissue ossifications, or they are not here, so psoriatic arthritis is excluded. Okay.
Sure.
Murali, last case. We'll quickly go through this.
Yes, sir. Thank you, sir. Yes. Dr.
Hi, Banu,
Rasmik
how are
Banu
you?
is here,
These
sir.
are two cases. This is the clue for this particular case.
1 second, sir. She has to switch on. Yes,
Hi, good morning.
No, we're not
Yeah,
able
sure.
to hear you. I think you have to switch on your audio button.
Yes, sir.
Okay.
Yeah. Are you able to hear me?
Yes, yes.
Yeah. Basically, this is the case, and this is the clue
Okay,
for
sir.
this case.
Okay, sir.
Yeah,
Okay.
describe.
A middle-aged man with the history of swelling and pain in the ankle. Provided images are ankle joint, AP and lateral view. And in lateral view, there is a soft tissue thickening in just adjacent to the posterior superior part of calcaneum. And in calcaneum, there is a prominent bony prominence of posterior superior part of calcaneum with a soft tissue thickening. The soft tissue thickening fills the inferior part of caecus fat pad, whereas a superior caecus fat pad is visible clearly. And visualized, there is no evidence of any lytic lesion or sclerotic lesion in the visualized calcaneum. And visualized other bony bones appears normal, and visualized joints appears normal, sir. So with this
exclude a terminology of visualized. Okay, whatever you see is visualized, right? Whatever you say that this is the findings in the given film. Okay, you are describing the film. Okay, non-visualized things anyway you are not going to describe. You avoid those things. Your description is perfect, and what you are thinking is.
Sir, with these X-ray findings, the history of swelling and pain, my diagnosis is Haglund deformity.
Okay.
With bony prominence.
So what is the criteria to say it's a Haglund deformity?
Sir, it will be a triad of.
It's a Haglund tubercle, to be precise. It's not a deformity. It's a Haglund tubercle. And what is the criteria to say it is a Haglund tubercle? Normally, also posterior superior aspect slightly prominent.
Okay, sir. It will cause in the insertional tendinopathy of Achilles tendon, sir. So
No. You are not listening my question. What is the criteria to say it is a Haglund tuberosity? Haglund tubercle. Normally, also will have a little bit posterior superior prominence here. There is a line known as pitch line. You have to draw from the anterior superior aspect to the. This line is parallel to this particular cortical margin. If it is significantly above, there is a bony protrusion that is called as Haglund tubercle. Not every posterior superior prominence we call as a Haglund tubercle. This is number one. Number two, your description of saying Haglund syndrome here is not at all valid. Number one is Haglund tubercle is not there. Number two is I gave you a clue. This is this.
Yes,
okay. This pathology is having a clue. This the Haglund syndrome is there. It should not happen in the hip joint, right? So take that clue.
Okay,
so then your Haglund syndrome, etc., are totally ruled out. You talk about differential diagnosis.
Okay, sir. Sir, coming to the left hip joint AP view, there is a multiple discrete lytic lesions in the leg of the femur, also involving the.
Tell me the diagnosis of this. This is a spotter.
Maybe it may be a PVNS, pigmented villonodular synovitis.
This may be a PVNS. This is a spotter, right? This is a spotter. Okay, you have to keep this in mind and then describe this. I said this is the clue. Then you describe this. And you have to keep that in mind when you are talking about that. So simply to finish off the last case earlier, I took this clue. Okay.
Okay, sir.
So there is basically a soft tissue density lesion here.
Okay,
usually, sir. What are the anatomical structures which are going to cause the soft tissue? There is a skin. There is a subcutaneous fat. There is a tendon here, tendon Achilles, and also a tragus fat pad.
Okay,
so there is a bursa. The retrocleus and calcaneal bursa. So this soft tissue density can arise from any of these anatomical structures.
Okay,
you have to tell that first. Okay. So then what are the things which you are going to do? It could be a soft tissue tumor. You don't know. It could be a lesion arising from the tendon sheath. We don't know. It could be a muscle infection, which you don't know, right? It could be a traumatic. If you can ask if there is a trauma, it could be a large contusion also. We don't know.
Okay,
so these are the possibilities on radiograph. It is not a bony lesion or a bony lesion going out of the bone and soft tissue because you said rightly pointed out that all the cartilages are intact. No lytic sclerotic lesion, calcaneum. So osseous lesions are excluded. Lesions are excluded. There is no trigonum to say there is os trigonum syndrome. Os trigonum syndrome is excluded. So your points coming here, soft tissue lesion. Then you ask me what do you want. Next investigation.
Sir, I want MRI, sir, to look for the soft tissue and to look for the another lesion, another PVNS here, or any soft tissue involvement.
This is MRI, but before MRI, you can always say, because it's superficial lesion, especially this in the region of endoechlis, coming into the region of endoechlis along to the insertion of the calcaneus, most probably a clue to you is this is coming and almost ending at the insertion of the tendoechlis. So this is possibility of there is a tendoechlis lesion, right? So tendoechlis is easily accessible to ultrasound. You first say that first investigation is ultrasound. Though I gave you MRI here. Okay, describe.
Provided images are STIR and T1, sorry.
Yeah, you tell me, this is a T2 and STIR, tell me.
Yeah, T2 and STIR images.
This is fat suppressed, yeah.
Okay, sir. The lesion appears hypointense. There is a soft tissue lesion arising from the tendon, Achilles tendon, which appears hypointense in T2 images, and in STIR also it appears mildly hypointense. And adjacent, there is adjacent fat stranding, and there is no evidence of effusion, sir. There is no evidence of effusion, and visualized.
So rest of tendons are not. So what is tendon? What is this tendon?
Sorry.
What are these tendons?
Peroneus.
Yeah, these two are peroneal tendons. These are FHS,
yes,
right?
Yes, sir.
Okay. So what is your differential diagnosis based on this?
My diagnosis is PVNS with soft tissue. Yes, so PVNS with soft tissue xanthomas.
Yes, this is, once they ask that, you know that there is a lesion here within the tendon, and you have to immediately say what are the lesions which comes from the tendon. It could be a ganglion, but this is not cystic, so you exclude that. It could be a GCT of the tendon sheath. Okay, that is also called a PVNS or whatever it is, genital tumor of the tendon sheath, and it could be a tuberculosis of the tendon sheath, but there is no bony involvement. So it just isolated tuberculosis, but this is not so common here in the ankle. And the other thing is fibromatosis. Fibromatosis also involves most of the times the plantar fascia, though the tendon sheath fibromatosis can occur, but it's very, very rare. So the common things are, it could be, it is a PVNS of the, I didn't have a gradient here, somehow I missed it, with the PVNS of the
Thank you so much, sir. Thank you so much, sir, for an excellent discussion on the MSK cases. Oh, sir, pleasure is ours. Thank you, sir. Yes, sir. Dr. Rajagopal, sir.
ನಮಸ್ಕಾರ. ಕೋವಿಡ್-19 ಅನ್ಲಾಕ್ ಪ್ರಕ್ರಿಯೆ ಈಗ ಪೂರ್ತಿ ದೇಶದಲ್ಲಿ
Yes, sir. Can you hear us?
Yeah, I can hear. Can you
Yes,
hear
sir.
me?
Yes, sir. We can hear you, sir. Thank you.
Yeah, I'm trying to share. Okay.
Yes, sir.
It's taking some time, I think.
Yeah, no problem.
Is it because of internet or what is it?
We are able to see you, sir, but we're not able to see your screen.
The screen. That's what I mean. Screen share, I did it, but anyway, I'll do it again.
Yes, sir.
What is the problem?
So can you do it again, sir? Can you log out and log in again, please?
Log out, completely go out and come back?
Yes, sir.
Oh. Hello. 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 Am I audible?
Yes, sir, you're audible, sir.
I'm not seeing the student. Hello. I see videos of myself as well as a student. Hello.
Yes,
Hello.
sir. You can hear the students, sir.
But I am not seeing the student here. Like how do you go to that?
Hello, good afternoon, sir.
So once you share the screen, you won't be able to see the students, sir.
Oh, student. I will not be able to see the student, is it? Okay.
Yes, sir.
Yeah.
So this is Dr. Rajkumar, sir. He's from Kilpauk Medical College.
Hi, Rajkumar. How are you?
Good afternoon, sir. Good afternoon, sir.
Yeah, good afternoon. First of all, I'm thankful to the organizers for inviting me here. So let us move on to the first case.
Okay, sir.
Yeah. Before that, I just want you guys to be, talking very confidently and talk loudly and clearly, right? So whenever you're presenting, you tell only the positive findings and relevant negative findings. Don't go on telling this is normal, that is normal, that is not required. And then you go to the diagnosis and then differential diagnosis in the order of common to uncommon conditions with respect to that particular imaging findings. Okay. And then importantly, you have to say what you want to do next. That's very, very crucial, right?
Okay.
So you had been provided with the 47-year-old, pain in the right hypochondrium. Okay, I had given you these images, but however,
Gopal,
because
sir, Oh, 1 second, sir. The others who are seeing are not able to see your video. 1 second.
Okay.
They will not see your slides. So how do we do it now? Tell me, Amit. Okay. Yeah.
Are you seeing it?
Mm-hmm. Yeah. Now he's turned the screen share off. Yes.
Are you able to see the screen or?
Reshare it again, sir. Yeah.
Okay. Okay.
Go to PPT, sir.
Go to
1
PPT.
second, sir. No, not stop sharing, sir. Hide.
Mm-hmm.
Now we are able to see.
Are you able to see?
Yes, sir.
Yeah. So what I'll do is I'll just quickly run the video of the
Sir,
case. Okay.
Yes. Okay. They're able to see now, so we can go.
Yeah. I'll show you the video, and then probably you can talk on, right? So because this is very selected images, no, you may find it relatively difficult to answer. Okay. I'll just show you the video of the case. This is a plain scan, right?
Okay.
This is a plain scan, and this is a arterial phase. Okay.
Okay, sir.
Just carefully see those images.
Okay.
Slowly, I'm just moving the slides.
Okay, sir.
You're able to see, no? Okay.
Yes, sir, I'm able to.
This is a portal venous phase.
Okay, sir.
This is a portal venous phase axial.
Yeah.
Okay.
I'm
Quickly
able to.
run through because that will be more useful to you because even in the exams you'll be seeing the entire case, no?
Yes, sir.
Okay. That is a portal venous phase, and this is a coronal portal venous phase reconstructed images. Okay.
Okay, sir. Okay, sir.
Yeah, I can carefully see this. So that is a very important image.
Okay, sir.
Even in the exam, they may give the clue, but because we have very less time, I'm just telling you. This is sagittal images, right?
Okay. Okay.
And now you can probably, talk about it. Okay.
Yes, sir.
So whenever you require, I'll show you those images. Right? Yeah.
Okay.
Go on, talk.
A 47-year-old female who presented with the right hypochondral pain. Now the selected axial CT plane and contrast enhanced CT images were provided, in which the plane image. Can I see the plane image, sir? Plane CT image.
Yeah. Whatever you say, I'll keep on showing. Right?
Yes, sir.
Okay.
In the plane CT image, I could able to see the large heterogeneous dense mass lesion in the right paravertebral region, abutting the vertebra, as well as the lesion is in the region of IVC extending inferiorly with areas of hypodensity indicating areas of necrosis.
Okay.
And there is no evidence of any calcification. With this image, I would like to do contrast. Next, I would like to move on to contrast image, sir. In the arterial phase, the lesion enhances peripherally, and also some regions of enhancement can be seen within the lesion, with few areas still remains to be unenhanced. It is extending into the in this arterial phase. It is seems to be in the same right paravertebral region and extending up to the right atrium. Okay. Next, in the portal venous phase, can I see?
This is the portal venous phase. Yeah.
Now in the portal venous phase, the lesion still the central enhancing part of the lesion enhances more progressively. Also, there is a displacement of the portal vein. Moving further inferiorly, the involvement of the lesion is seen mostly within the hepatic segment and the middle segment of the IVC, that is between the hepatic and the renal vein confluence. Further, when moving further below, the distal aspect of the IVC seems to be opacified, whereas on moving further in the coronal section, I'm able to see that the left side hemiazygous vein seems to be more prominent and dilated, so that since the lesion is causing complete blockade of the vessel lumen, the entire blood in the vein is shifted towards the hemiazygous vein, with multiple collaterals located on the left paravertebral region, which can be more clearly seen in the axial images. In this coronal image, I could more easily appreciate the hemiazygos vein, the shunt of the blood from the IVC to the hemiazygos vein. Further, the lesion does not contain any fat content. Also, in this coronal and sagittal images, I could see the extent of the lesion towards the right atrium.
Yeah.
Putting it also, I could able to visualize the free fluid in the pelvis.
Okay.
Now the lesion seems to be well defined within the intraluminal, but in the axial section, I am not able to clearly demonstrate the wall lumen, clearly delineate the wall in the, so that there could be any possible extension into the liver. So putting all together, I would like my principal diagnosis is leiomyosarcoma of IVC, since the tumor is principally located within the IVC, that is hepatic and middle segment of the IVC. The next differential diagnosis I would like to include are liposarcoma, but since the lesion does not contain any fat content or calcification, I won't consider this as this could be a primary diagnosis. The next most common differential diagnosis I would like to include is undifferentiated pleomorphic sarcoma, where it will be more common in males. Number one. Number two, it will have extensive hemorrhage as well as the calcification component. But in this case, we don't have extensive hemorrhage as well as no calcification. So putting it all together, I would like to say this as a retroperitoneal leiomyosarcoma involving the middle and the upper segment of the IVC with possible extension into the right atrium. Further, to confirm the diagnosis, I would like to proceed to do image-guided biopsy. So after confirming the diagnosis, further, I would like to do a metastatic workup and look for metastatic workup and a resectability of the tumor. So my principal diagnosis is leiomyosarcoma of IVC, sir.
Yeah, excellent presentation. I think you got nearly 70% of the marks already. Okay. And the only thing is some of the things you're not told. I told you when you're talking about the positive findings, you have to tell the relevant negative findings to rule out some of the other stuff, you know.
Oh, yes, sir.
Like, for example, there may be tumor going into the IVC, like retroperitoneal sarcoma going into the IVC, or yes, it may be adrenal carcinomas going to IVC, or kidney tumor going into IVC. So yes, you have the relevant negative findings there. You have to say, so whatever the important structures like the kidneys are normal, adrenals are normal. You're trying to rule out some of the tumors going into the IVC, right?
Okay. Yes.
So your diagnosis is absolutely right. But in addition, I wanted you to say something else. What is happening here?
To confirm it to be in the...
No, to confirm that you said that those aspects absolutely fine. No, but what is happening to the liver?
Yes, sir. It is being invaded.
You think liver is invaded by the tumor in the IVC, or what are you talking about? Yes, why do you think there is an invasion to the liver?
Sir, here I am able to see the entire lumen of the IVC, which is grossly distended.
No, that is okay. What is happening to the liver? And any particular structure you want to say here?
Sorry, sir.
Because IVC is completely filled up now.
Yes, sir.
Would you like to see anything else in the liver?
As a part of complication, Budd-Chiari syndrome has to be considered.
Yeah, absolutely. That also you should have told, that you missed, right? Yes, if you tell all those things, no, you will get almost 80%, 90% range. So here the hepatic veins are not seen, no?
Not seen, sir.
Yes. And what is the enhancement pattern of liver here?
Here it is a
heterogeneous. Yeah, heterogeneous enhancement. So what happens in the chronic Budd-Chiari syndrome?
Flip-flop phenomenon is seen, sir. Where there is
because you will have the regenerating nodules coming up, vascular regenerating nodules, no?
Yes, sir.
So very heterogeneous enhancement. So there is definitely a Budd-Chiari syndrome in this case. So
Yes,
you're very sure, no?
Yes, sir.
And then you told about the extent, which is very, very important for the management per se. Like if they want to resect the IVC, you're telling that it's involving the suprarenal portion going into the like atrium and all that. Those things are very important. That you told very perfectly, right?
Okay.
Right. So excellent presentation. And yeah, the differential diagnosis you said already.
Yes, sir.
And like is ultrasound useful here?
Yes, sir. Ultrasound is mainly useful to visualize the before CT cross-sectional imaging. We can see
No,
the
even if CT if you do, so ultrasound is useful in some extent.
Yes, sir. Image-guided procedures can be done.
There you're not very sure like what is the fat pain between the IVC and liver and all. No?
Yes,
if you do the ultrasound properly, you can see that. So you can definitely make out slightly better. So definitely within the IVC, it is not coming from the liver and all. And some of the signs you have to say like what are the signs, right? Imperceptible. Like some of these things probably you can say like IVC is not separately visualized, right?
Yes,
so you demonstrate your knowledge, right? How you perform in the exam depends on how you demonstrate your knowledge, right? So diagnosis is absolutely fine, but this you missed up. Okay, Budd-Chiari syndrome causing that you missed. Okay, there's significant mass is lost there, right? So the differential diagnosis you said retroperitoneal sarcoma absolutely fine, and the other differentials that you want to look for while ruling out the other lesions like renal cell carcinomas, adrenal carcinomas, those you must say, right? And grading, which helps in the management that you already told, right? In Budd-Chiari syndrome. This is another case of Budd-Chiari showing a very classical IVC. I mean, hepatic veins are not seen well, and the IVC here grossly narrowed, right? So why that is important? What are the? Do you know the like? What are the interventions that you can do in these cases, Budd-Chiari, if it is not a tumor-like thing? Like if it is only hepatic vein occlusion, so what are the treatment that you can offer?
Sir, the other treatment, if it is not if it is definitely a bland thrombus, I would like to do a thrombectomy, IVC filter, and
IVC filter, like for example, hepatic veins are occluded, the IVC is still patent. Then what do you do?
I would like to do shunt management, sir.
What shunt? How do you do the shunt? Yeah, either balloon angioplasty or stent insertion. So if it is only IVC stenosis, then you have to put a stent in the IVC, no?
Yes, sir.
So none of these, if it is working, sometimes tips may be useful, and liver transplantation may be very curative in some of these conditions, right? So if it is not a tumorous condition in Budd-Chiari syndrome, right? Okay, thank you so much. We'll move on to the next case, right?
Thank you, sir.
Thank you. We have next Dr. Anup.
Yeah.
Hello?
Yeah. Hello, Anup.
Good morning, sir.
Yeah, good morning.
Switch on your video.
Sir, good morning, sir. My name is Anand.
Dr. Murali, probably while presenting, if you're seeing the students, no, actually it's much more interactive. I'm not able to see the students.
Yes, I think
and maybe some technical improvisation you can do. Because I'm just talking.
Actually, I am able to see, sir, but I don't know why.
But if I move on to that presentation mode, no, nothing else
correct.
apart from only the presentation.
Other than you, all of us are able to see.
Yeah. Other than me, so I should be able to see the student. That is the thing.
We'll work on it, sir.
Okay, right. Yeah, and Anup had given these two slides. Okay, these two slides. Sir. But I'll show you the entire case, and I can talk on.
Sir, I'm not able to see the slides, sir.
Are you not able to see the slides? How is that, man? Dr. Murali?
I am able to see it.
Should I share it again?
Yes, sir.
Why these things happen? Okay. Are you able to see?
Yes, sir.
Okay.
Okay. Yeah. What's his name? Dr. Anand, no?
Anup, sir.
Anand, sir.
Dr. Anand. Okay. Dr. Anand, I'll show you the. I'll run the video, and then probably you can talk on. What is this sequence?
The T2 sagittal, sir.
T2 sagittal, right? So I'll run the video, and then you can talk on. This is T2. Some of the images were already given, but I'm running the video so that it will be more useful to you. what is this sequence?
Again, T2 axial, sir.
T2 axial, fine, excellent. And then what is this sequence?
The coronal sequence of T2.
Coronal T2, fine, excellent. So whenever you're presenting, so you have to talk about the age and sex of the patient, and then talk about the sequence, and then you start the presentation if MR is given, right?
Yes.
Yeah. So I'm just running the video, and what is this sequence? Dr. Anand.
T2, sir.
This is not T2. This is a T1 weighted. T1 axial. Okay. So why I'm telling you is that that's very important when you're diagnosing the case. Okay. And then what is this sequence?
Fat suppressed sequence.
Yeah, fat suppressed T1. Okay. Yeah. This is fat suppressed T1. That was T2. Okay. That was star, and then this fat suppressed T1. Okay. And then I'll show you that this is post contrast.
Yes, sir.
Post contrast, fat suppressed T1. Okay.
Yes.
You can see it now.
Yes, sir.
Just keep on seeing the findings when I'm scrolling through, and then you talk about it, right? And then this is post contrast and T1 fat suppressed. And this coronal T1 post contrast fat suppressed. Okay.
Yes, sir. Yes.
And then so whatever the sequence you want, I'll just show you. Okay. And then talk on. Okay. Yeah. Present the case.
I've been provided with films of a 59-year-old lady, MRI pelvis, T2 sagittal axial, T1 axial, and T1 and T2 fat suppressed sequences. The T2 sagittal sequence shows a large, well-defined cystic lesion in the right adnexa to midline location with a large, irregular, solid component arising from the right posterolateral wall. The capsule of the cyst is intact.
What did you say? Right posterolateral wall?
The solid component.
Okay, fine. Yeah.
Good. The fluid is of homogeneous signal intensity. The solid component is of heterogeneous signal intensity with post-contrast enhancement in certain areas. The capsule is of the cystic lesion is intact. The ovary is not separately visualized, neither the right nor the left ovary. The mass causes mass effect on the adjacent structures, causing inferior and posterior and left side displacement of the uterus and inferior displacement of the bladder. There is no involvement of the adjacent pelvic organs. The fat suppressed images shows crescentic intraperitoneal hyperintensities which represent ascites, mild ascites.
Yeah. That you're seeing only in a post contrast scan. Okay. In plain scan, that was not seen, right? No. Yes. When in post contrast scan, that was seen, right?
Yes.
So this is still plain. Yeah. Go on.
The neurovascular structures are displaced. There is no obvious lymph node enlargement in the visualized pelvis. No peritoneal deposits. Summarizing, in view of a 59-year-old lady with lower abdominal pain, presents with the solid cystic mass centered in the right adnexa extending to the midline, with intact capsule and no involvement of adjacent pelvic organs. In view of the age and the findings, my differential diagnosis would be that of a serous cystadenocarcinoma of the right ovary. The left ovary cannot be visualized separately. The mucinous cystadenocarcinoma is less likely because of the homogeneous hyperintensity in the T2 sequence of the fluid. Additionally, I would like to review the rest of the abdomen and do a chest X-ray to rule out pleural effusion. Biochemical, I would like to do CA-125 levels to calculate the risk of malignancy index. An ultrasound would further confirm the presence of any septae which are not very obvious in this MRI. Whether the septae are present is multiloculated and thickened.
Yeah. Yeah, good presentation, but some of the things I think probably you missed up. So what is this sequence?
This is the post-contrast T1. Sorry, T1 fat suppressor.
So T1 fat suppressed. And Not a post contrast. Okay.
Plain.
There's a plain scan, right? Okay. So is it giving any further clue what you're dealing with? Yeah, this is the post contrast. Okay, this is the post contrast. Post contrast. So in between, actually, the cyst was ruptured, and you're seeing some hypertensive fluid within the ascitic fluid. Okay. So yeah, again, is this giving any clue? So what is the inner content of the lesion?
Predominantly cystic with a solid, irregular solid component.
No, that is okay. What is inner? Why it is looking hyper intense and plain fat suppressed T1 weighted images?
Either it could be hemorrhage, sir, or mucinous material.
Yeah, absolutely. Yeah, you're right. But significantly, it's even signal intensity quite more. No. So in what scenario you get T1 hyper intense signal within the cyst?
If it is mucin, sir, thick mucin.
No, apart from mucin, you leave that mucin at the moment. It may not be so hyper intense as you see. It won't be so hyper intense as you see here, right? Even T1 fat suppressed very brilliantly hyper intense, no?
Yes, sir.
So what could be the other content? You said it's hemorrhage, no? If it is hemorrhage,
no layering.
No layering is also not there because of some reason. I'll tell you later on. Okay. Still consider this as hemorrhage. What could be this? Can it be some kind of endometriomas?
Yes, sir. Possible. Yes, sir.
Possible. If it is endometrioma, anything else you're seeing further? Are you trying to document the characterization of this endometrioma? Is there anything else within the cyst? So you're seeing a lot of solid component within the cyst now.
Yes, sir. That might be the thrombus.
Thrombus? No, it's solid components which is enhancing the post-contrast scan.
Yes, sir.
Enhancing the, what does it mean? Can endometriomas, can it turn malignant?
Oh, yeah. Yes, sir.
So if it is malignancy, what are the features that comes into picture? So what kind of malignancy that you can see in endometriomas? Yeah, some specific two varieties, no?
Yes, sir. Could be the endometrioid cancer.
Yeah, very good, very good. That's one. And then the other one is clear cell carcinomas, right?
Yes, sir. Yes,
so whenever you're seeing solid component within these endometriomas here, which is enhancing the post-contrast scan, you have to think about in those lines, right?
Yes.
So do you want to revise your, and why it is rupture? Like what are you seeing in ascitic fluid? Why it is hyperintense and
yes, it is also hyperintense. So the fluid from within the cyst has
yeah, that is also essentially hemorrhage.
Yes, sir.
Okay, hemorrhage. So what is your final diagnosis?
Endometrial malignancy.
Yeah. Complete diagnosis.
Right ovarian malignancy, endometrial type with likely to be a clear cell carcinoma.
Yeah, maybe endometrial carcinoma. Yeah. So histologically, we're not asking you. So essentially, what is happening in the at least within the endometrioma, some kind of malignant degeneration. No.
Yes.
So ovarian endometrioid carcinomas. Actually, on sagittal sequences, you're not very sure whether it's arising from the uterus or not.
Yes, sir. Yes, sir.
Were you 100% sure that it is definitely adnexal mass?
Sir, the angle of contact between the uterus and the mass seemed acute. So that is why I didn't feel it was uterine.
Absolutely right. You're fine. So even on table also, they were not able to localize whether it's arising from the uterus or is totally stuck to the uterus, right?
Yes, sir. Yes.
So even if you give other differentials as uterine sarcomas or large degenerated fibroid with hemorrhage, that is also fine in this case. Okay.
Okay.
Yeah. Especially the endometriomas can have harbor the malignancy rarely, right? And what are the imaging clues essentially? So if you see the enhancing the mural nodule, that's very, very important. There will be loss of T2 shading, unlike endometriomas. No, if it is a malignancy, there can be loss of T2 shading, essentially because of dilution of hemorrhagic content by the non-hemorrhagic fluid. okay, secreted by these solid compounds, right?
Okay, sir. Okay.
And neural nodules, if it is more than 3 centimeter, or interval increase in the size of the stress, that is also sign for the malignancy. Okay, and associated abnormalities that you need to look at. It can be associated with the endometrial hyperplasia or carcinomas. So,
sampling
probably if you answer everything, they'll ask about all these things, associated abnormalities, right?
Yes,
like Lynch syndrome and all. Please go and see it. Okay, and nearly up to 40% of the cases of endometriosis, like these cases may have the endometriosis also elsewhere. Okay,
sir.
That may give you further clue that you're dealing with the endometriomas. That you need to look at. Right. So when you're telling the relevant negative findings, you have to talk about all those things, right?
Yes, sir.
So all the differential diagnosis probably you can see, and you already told about these things, but you didn't talk about endometriomas or clear cell carcinomas. That is not right. You were talking only focusing only on the serous adenoma carcinoma or mucinous carcinomas, right?
Yes, sir.
So you have to see entire talk about. You have to look into this signal intensity and different sequences, and then you have to come to conclusion. Don't jump to the conclusion. That's very important, right?
Yes.
Okay, good presentation.
Yes.
Essentially, you cleared that exam, no doubt about it, and congratulations for that. Okay, so we'll move on to the next case.
Yes, sir. Yes, sir.
Yeah. Hopefully, we're in time. I think because I'm a last presenter, maybe I'll get a little more time. I'm not
we can do all the 6 cases, sir. We can do all the 6 cases.
Oh, good. I'm happy for that. Right.
Yes.
And then, is there any case 6? Anyway, you're giving my.
Send me case 6.
All 6 I can finish. So
yes.
There's no problem. So the third presenter.
Dr. Anup, are you here?
Yes, sir.
Yes. Can you switch on your video?
Yes, sir.
Yes.
Only I'm not seeing him. Dr. Anup, how are you today?
I'm fine, sir. Thank you, sir.
Yeah, be confident and talk about it.
Yes, sir.
So I've given you these images.
Yes, sir.
You want to talk about it, or you want me to show the additional history I have written here?
Yes, sir.
The rapid drop in the hemoglobin.
Yes, sir.
I'll show you the video of the rest of the images, and then you can talk about it. Okay.
Sure, sir. Okay, sir.
Yeah. This is a plain scan.
Yes, sir.
I'll just run the video.
Yes, sir.
And yeah, this is the arterial phase. Again,
yes, sir.
The arterial phase which you have seen already.
Yes, sir.
And this is the portal venous phase.
Yes, sir.
And one image already I had given, and this coronal scan also I think I had given.
Yes, sir. Yes, sir.
Okay. Yeah, and this is the delayed images. Okay, which
yes,
I probably had not given. Please have a look at it. Right.
Yes, sir.
Yeah. Sorry. Yeah. We'll go back to that, and then so whatever the images that you require, I'll just put it and talk about it. Dr. Anup.
Yes, sir. Sure. Yes, sir. Okay, sir. Plain CT images of a 55-year-old male shows a well-circumscribed isodense lesion in the right lobe of liver with a central hypodense areas. No evidence of calcification or hemorrhage within the lesion. The liver also appears slightly cirrhotic because the caudate lobe of the liver appears to be enlarged. That is widening of fissure, and that is slight nodularity of the surface of the liver. Apart from that, on the plain CT images, I can also see some free fluid within near this spleen, sir.
Mm-hmm.
Then
yeah.
Then there is widening of fissure. There is a mild caudate lobe hypertrophy, which is displaced by the lesion. And apart from that, the arterial phase, sir. Can you see the arterial phase, sir?
Yeah. No, in plain scan, do you want to see anything else? Where is the caudate lobe? Like, do you think this is the caudate lobe?
Yes, sir. I think that is the caudate lobe, sir.
Do you think that is the caudate lobe? Just I'll show the inferior images here. This is not the caudate lobe, no?
No, sir. No, sir.
And this is the pancreas here. Okay. I'll show the post-contrast scan. Probably you can figure out what is happening there. Okay. Yeah. Post-contrast scan. Arterial phase. You wanted. Yeah.
Yes, sir. Post-contrast scan. Post-contrast scan. That is arterial. In arterial phase, there is a mild enhancement with multiple arterial feeders arising from the right hepatic artery.
Very good.
There are few hypoenhancing areas still present within the lesion. May represent necrosis. There is another. The rest of the liver parenchyma appears normal. There are no other lesions. I would also like to
the portal venous phase. Yeah, you talked about it.
Yes, sir. Portal venous phase. The portal vein is showing no filling defects, sir.
Okay, good.
So portal vein, both the portal branches are not showing any filling defects.
Okay.
There is no portal vein by the mass in the right lobe of liver.
Okay.
The
a little bit faster.
Lobe of liver. There is one more mass.
Yeah.
There's one more mass, sir.
Yeah, good. Yeah.
Which is appearing hypo-enhancing on venous phase.
So what is that you're talking about, the caudate lobe? So what is happening here?
It is hypo-enhancing, sir, compared to...
Yeah. So if it is a caudate lobe, probably it would have enhanced similar to that of the rest of the liver, no?
Yes, sir. Yes, sir.
So why it is not happening? And that was looking more hyperdense on plain scan. So if you go back to the plain scan, it's slightly more hyperdense to the rest of the liver also. Okay.
Yes, sir.
So what is that?
Could it be a regenerative nodule, sir? Like
such a large regenerative nodule. So see, this is the pancreas, no?
Yes, sir. Yes, sir.
So something is happening here and then going into the region of the lesser sac. Yeah. Something is happening here and then going to. What is that? There's a drop in hemoglobin, no? Additional history was given. And here also you can see something here. What is that? Can it be bleed?
Yes, sir. Bleed, sir. Hemoglobin drop is there. So it can be a rupture of any...
Yeah, why you're struggling with that? I'm giving you all the clues. Even in the exam, the examiner will give the clues, okay? Please,
yes,
sharp enough to get those clues. Those are very important, right? Okay, I see there is a significant bleed. So what are you dealing with?
Could be a rupture of...
this is the post-contrast scan. I mean, delayed scans.
Yes, sir.
What is it showing? No, sorry. The delayed scan.
The right lobe is showing persistent enhancement, sir.
No, specifically, you want to look at anything in the delayed scans? What is this?
The capsule.
Yeah, capsular enhancement. You have to appreciate, no? And then what is happening to the tumor per se when compared to the rest of the liver? Sometimes the washout is you may not be able to appreciate on the portal venous phase, but you need to look at the delayed images also to look for the washout. Okay, which is very important for the diagnosis. So, is there any washout?
Yes, sir. There is some.
There's subtle washout. Is that okay?
Yes.
So tell me about what is your diagnosis now? And is it a hepatic lesion?
Sir, in the delayed phase, I can also see that.
No, is it a hepatic lesion or a non-hepatic lesion?
It is a hepatic lesion, sir. It's arising within the...
how do you say it's hepatic lesion?
Sir, it is receiving branches from the right hepatic artery, sir. One, it is a feeding artery sinus there, sir. That
excellent, excellent. Yeah, excellent. That I want you to say that. And so rest of the organs are seen separately. And it's also fed by the hepatic artery. So obviously you're dealing with the hepatic mass, not a adrenal mass and those things, no? In this case. So now it's some kind of bleeding hepatic lesion. So what is our differential?
One would be hepatocellular carcinoma, sir, because bleeding of a hepatoma is common. There will be a rupture of, but
good. Yeah. What are the other lesions that can bleed within the
hepatic adenoma, sir?
Hepatic adenoma, fine. Yeah. Would you like to consider that here, or is it HCC only?
Sir, since there is cirrhotic background and
not a cirrhotic. In that way, actually, I'm not seeing quite significant cirrhosis here. Whatever you're talking about,
bulging of fissures. So this.
Yeah. Okay. Anyway. Yeah. So apart from that, anything else? To call it as a HCC, may not be adenoma.
So
Okay. Yeah, the
that-
capsular enhancement is also there, no?
capsular enhancement is also there. Yes, sir.
Yeah, and you're seeing some multicentric lesion, and even hepatic adenomas can be multicentric. Okay, but there's a good differential. And then what else? What are the other lesions that can bleed? Okay. Even large hemangiomas also can bleed.
Large
Okay?
yes, sir. Okay, sir. Yes, sir.
Lesion like this, exophatic lesion and large hemangiomas can bleed. Okay.
Yes, sir.
And so, what do you want to do in this case? How do you help the patient? And hemoglobin was nearly 5 gram%. Yeah. As a radiologist, what you can do, man?
We can do hepatic artery embolization, sir. Like
Yeah. Okay. Yeah. What kind of embolization you want to do here? Anyway, you have to stop bleeding. No, you have to do the embolization.
yes, sir. Transarterial chemo.
Yeah. Anyway, all the way you're taking the catheters there, and so otherwise the patient, the parameters are fine. The liver parameters are fine in this case. So you can do the test, no?
Yes, sir.
Okay. So what is the embolizing agent, and how do you do it? What material you want to put? Do you know about the intervention test, or you're not exposed to it? Dr. Anup, are you there?
Yes, sir. I'm there, sir.
Hi. No. If you don't know, please tell. Even in the exam,
yes,
I don't know, and then they'll move on to the next question. Okay.
Yes,
so you get stuck there, and so I'll be thinking probably you're trying to answer it. Do you know it or not?
No, sir. No, sir.
Yeah. The common. What is the material that you put along with the lipidol?
Gel.
What chemotherapeutic agent? No, initially only you don't put gel foam. Okay.
Okay,
You mix the chemotherapeutic agent. What chemotherapeutic agent? Either doxorubicin or nowadays we use epirubicin. Okay.
Okay, sir.
So
Yes.
you mix along with the lipidol, and then you put it. So
Yes.
at the end, to block the artery to prevent the forward flow, then you put the gel foam or the PVA particle. Okay. Not
Okay,
in the
sir.
beginning. Not in the beginning.
Okay,
Okay.
sir.
Yeah. In the exam, actually, you need to know the. First of all, they'll start talking about the anatomy of these blood vessels, and then so what kind of catheters that you want to use. Sure, what is the catheter that we use? What is this catheter?
Hello.
Yeah, what catheter? Probably you're not aware of it. Please go and read.
Yes, sir.
Usually we use a SIM1 to hook the celiac artery. Sometimes you have to know the arterial anatomy also. Sometimes the right hepatic artery can arise from the SME also, right? So
Yes.
first of all, beforehand, you need to know about the anatomy and then go into the lesion. So many times we see significant percentage of these patients may have right hepatic artery from the superior mesenteric artery, replaced right hepatic artery. So usually use this SIM1 catheter and then use the microcatheter to go very selectively into these blood vessels, and then you inject, right?
Yes.
This is post embolization. So what is this post embolization? What have you seen?
Sir,
Why it is looking very dense?
sir, multiple
No. Again, it's just a lipidol you put, no? That's a deposition within the tumor.
Yes, sir.
Okay. And do you know about the LIRADS?
Yes, sir.
LIRADS, you have to, I think, relatively mug it, no? Just for examination sake. Although too many things are there in this, but at least when you call it as a definitely malignant lesion, that you must know, right? So when do you want to call it? Already in front of you, is it?
Yes, sir.
Slide is there.
Yes, sir.
So when do you call it as definitely malignant lesion? Definitely HCC?
Sir, when there is washout, sir, complete washout.
I know. Before washout, what do you have to say, man?
Size, sir, size of the lesion.
Size of the lesion is important, and then you have to talk about what is this?
Enhancement, sir. Arterial phase
Arterial phase enhancement. That's very important. Size of the that is very important. Then you talk about the washout, and then you talk about capsule and those things. Okay. So
Yes.
depending on this, so you have a different scores, no? Right?
Yes.
So that you have to really when do you want to definitely call it as a malignancy. Okay.
Yes.
These are the other cases, multiple hepatic adenomas with bleed in this case, and hemangiomas with bleed. So
Yes.
you have to know, as an MD student, even if you're not doing, you have to know about the interventions. Okay. So when
Yes.
do you want to do the RF ablation? When do you want to do the TACE? When do you want to do the transarterial radioembolization? Those things, right? So treatment options also you must know. When you want to do the surgical excision, right? Ideal candidate is essentially small peripheral tumors without vascular invasion. Okay. So when do you want to do the RF ablation?
When the
I'm just telling you, but at least go through it, right?
Yes. Okay, sir.
Small lesions less than 3 to 4 centimeter, right?
Not suited for
So
surgery.
they're a very ideal candidate for radio frequency ablation. So transarterial embolization, especially if it is a multicentric tumors, so you prefer transarterial. If it is only single lesion less than 3 to 4 centimeter, that's ideal candidate for RF ablation. Given the anatomical location also, okay, that's also very important. If it is very close to the portal vein, large portal vein, and there can be heat sink effect. Okay, what is heat sink effect? In a radio embolization, radio frequency ablation, what is the heat sink effect?
The vessel surrounding the lesion will take up the heat, sir. That.
So what will happen? What happens to the tumor ablation?
Ablation will not happen properly.
Yeah, because in the tumor adjacent to those vessels, so may not ablate completely, right? So you have to know about the indications for TACE as well as TACE is essentially an alternative for TACE. And when you want to do the transplant, okay, you know the Millen's criteria. So I've given it here, right, for the transplantation. Solitary HCC is less than 5 centimeter, or if it is 3 HCC, up to 3 HCC nodule less than 3 centimeter in diameter. Okay, if there is no vascular invasion or the extrahepatic spread, so they are ideal candidates for liver transplantation, right? Even in those people with liver cirrhosis also. So there should not be any extrahepatic spread of the disease, or and then if nothing works out, a systemic therapy with sorafenib. Okay.
Yes.
Okay. Then, thank you, Dr. Anup. No.
Yes, sir. Yes, sir.
Yeah, please go through the intervention for MD students.
What was the final diagnosis? What was the final diagnosis, sir?
It was HCC, bleeding HCC.
Okay, sir. Bleeding HCC. Yes,
and yeah, we've done the test also, no? So obviously, because it was almost definitive. So if you take the LIRADS, it comes into LIRADS 5 now.
Yes, sir.
Yeah, because more than 2 centimeter lesion, arterial phase enhancement. The washout you're seeing in the delayed phases, you may not see in the portal venous phase. Capsular enhancement, then what else you want? So it's almost definite HCC. You don't need to do the biopsy also before doing the TACE, okay?
Yes, sir.
That's why probably I didn't tell you that the different diagnosis in
other lesion in the left lobe of liver, sir. The one I thought was the caudate lobe.
Yeah, the caudate lobe, that was just a bleed, man. Just adjacent to the lesion, that was just a bleed from the tumor. It is bled there, and it is going to the lesser sac.
Yes,
you know the recesses of lesser sac.
No, sir. I'll read it.
Superior recess, inferior recess. If you carefully see it, you are seeing all the entire anatomy of the lesser sac, the recesses here in this example. Okay.
Yes, sir.
For that, please go and rate. Right?
Yes, sir. Thank you, sir.
We have to move on to the next case.
Yes, sir. Thank you, sir.
Murali?
We are ready, sir.
Okay. Yeah.
Dr. Kritika is here, sir.
Hopefully, still have time to go through all the 6 cases, or?
Yes, sir. We are if you are
good,
okay,
good.
then we can go, sir. Yeah, no problem.
Yeah, no, I'm absolutely fine. I'm happy to be with the student. Okay.
Great.
Right. So
This
we'll
is
move on
Dr.
to the next
Kritika,
case.
sir. She's from Stanley College. Yes, sir. She's from Stanley Medical
Okay.
College.
I could have seen her face anyway. Are you seeing the images, Dr. Kritika? Hello?
Yes, sir. Thank you.
Yeah, these are the images that were provided to you earlier. So I'll give the enlarged images of these, and then you can talk about it. Yeah, please go on. Present the case.
45-year-old man with recurrent constipation.
Your voice is a little bit of some disturbances there. Okay. Yeah. Dr.
45-year-old man. Yes, sir.
Yeah, go ahead, Kritika.
Go ahead.
40-year-old man with recurrent abdominal pain and constipation. X-ray abdomen have been provided. Here I'm able to see the descending colon and the sigmoid colon are featureless with shows mild dilatation with evidence of thumb printing and the lateral aspect of the descending colon. And the sigmoid colon also appears mildly dilated and they are featureless. Not able to see the rectal gas shadow in this image.
What is the normal diameter of the large colon up to? What is the range?
Up to 5 centimeters.
Yeah, I think it is more than 5 centimeters. Yeah, okay, good.
It's
Be
dilated.
confident. Be confident. Whenever we are asking, sometimes we want to see your confidence. Okay. Yeah.
So they are peripherally. And with the history of recurrent abdominal pain and constipation, and with these features of featureless colon in the descending colon and sigmoid colon, and absence of rectal shadow, and there are some features of thumb printing in the lateral aspect of descending colon. My principal diagnosis with these features include colitis, possibly ulcerative colitis.
Yeah.
And since rectal gas shadow is not seen, this could be associated with some large bowel obstruction, maybe possibly due to some secondary carcinomatous changes in the distal sigmoid colon.
Yeah. Anything else you want to comment here?
There is no evidence of any sacroiliitis, and visualized skeleton appears normal. There is no evidence of any mass lesion noted in the visualized image, and there is that's all, sir. No other relevant negative features.
No, anything else you want to check? You're talking about could be some kind of colitis, no?
Yes, sir. Yes.
So how do you proceed when you're talking about a colitis? What do you want to do next?
Colitis, I want to rule out the cause by doing cross-sectional imaging, sir. Next, or we can go with the fluoroscopy, barium enema.
That is as a radiologist, no? Okay. Usually,
Yes,
what do they do?
Laboratory correlation. We can go with laboratory correlation of any increased counts.
Anything else? Some kind of scopies?
Yes, sir. We can go with sigmoidoscopy or colonoscopy. And we should confirm the diagnosis only by colonoscopy guided biopsy.
Yeah, you're talking about.
But before that, we should rule out ischemic colitis by doing cross-sectional contrast imaging.
Yeah, good. So anything else you want to see? What, like you're talking about, you can do the barium enema and all, no? So
Yes,
on the plain radiograph, you want to comment on anything else?
Yes, if we are planning for barium enema and all, we should rule out toxic megacolon, which is a contraindication for barium enema. And the transverse colon diameter, we should see whether it is grossly dilated. And I don't look like it's that much dilated in this case, sir.
That is what I wanted
if it is
from
more
you.
than 9 centimeter,
Yeah.
If it is more than 9 centimeter.
Yeah, usually more than 8. Okay.
Okay, sir.
Yeah.
The transverse colon, so there is no features of toxic megacolon.
So whenever you're presenting, relevant negative findings are very, very important. Okay. So essentially you're dealing with the case, like you're performing in the exam. That is what is important. So you should have talked about the caliber of the transverse colon also. Okay. So if the caliber is too big, probably you don't go ahead and do the barium enema or okay. If it is toxic megacolon, even scopies also they don't do, no?
Yes, sir. It's a contraindication for toxic megacolon because it can perforate.
Yeah, that is why. So you need to comment about those things. So exactly, you told about this thumb printing. That is very, very good. So many students don't try to figure out these things, and you told about the featureless colon. All excellent. So you already told most of the diagnosis in one film. Very nicely done. So what is this showing? This film. What is this film? Hello.
So this is the next film is the erect X-ray abdomen erect image. and I'm able to see multiple air fluid levels in the large bowel scenes.
Yeah, okay.
So this could be a feature of
Yeah.
obstruction. Because of
Yeah.
obstruction, there are multiple fluid levels.
Anything else you want to comment here?
So there are more probability of distal obstruction because of secondary to colitis.
No, that is okay. In this film, anything else you want to comment?
No evidence of air under the diaphragm,
Yeah.
sir. There is no subphrenic gap.
Well, why you have to comment in this? You
Because
talking about
since
toxic megacolon which can perforate and all, no? So
Yes, sir.
at
Yes,
least
sir.
you have talked about those things, right? So even small bowel also is showing a little bit of air fluid level. So why?
Small because of obstruction, there will be proximal dilatation of small bowel loops, and that could
Yeah.
also may show air fluid level.
Especially the ileocecal valve is not very competent, so they can have the small bowel dilatation also, right? In
Yes,
large
sir.
bowel obstruction. So this is this I just kept because you're talking about air under the diaphragm, no?
Yes, sir.
So
So
which is the
X-ray
best,
chest is for
which is the best film to see the air under the diaphragm?
X-ray chest erects.
What is the reason? Why not the abdomen?
The parameters KVP and MA we use in
No, not because of that. Anything else? Some subtle pneumoperitoneum you can miss in abdomen
Sir,
erect film, but you can detect
I
in.
think she,
Hello?
sir, I think she had an internet
Even
problem.
the-
Yeah, and now she's come back.
Oh, she's come back.
small.
Yeah, why chest X-ray is important?
Hello.
I was asking you. This is a very favorite question for the, especially the world examiners. Hey, tell. No, there is some problem with her audio.
Yes, sir.
1 second, sir. 1 second. She's coming.
Sir, can you hear me now?
Yeah, now I can hear. I think, yeah, the why chest X-ray is important. Is more like, especially if you're looking here under the diaphragm, no? What is the reason?
Yes, sir. Because of the contrast resolution between contrast resolution. Can you hear me, sir?
Yeah, I can hear you. Please go on.
Hello.
Yeah, please go on. Hello, I can hear you. Hello, Dr. Murali?
No, I think yes, sir. Sir, we are not able to hear her. I think she's got some internet issues there.
I think should we move on to the next case then?
Yeah, yes, sir. You just finish this case and we can move on to the next case. Yes.
But I'm not hearing her. No. Hello.
No, sir. You can finish this case, sir. You can finish it by yourself, and you can just.
Yeah.
Go to the next case.
Okay. The CT was done anyway. She was talking about it. She wants to do the cross-sectional imaging, right? So the CT is essentially showing the featureless descending colon, as well as at the rectosigmoid junction. There's a eccentric wall thickening of the rectosigmoid junction, consistent with probable malignancy. So whenever you get any case like this, you have to look for the complications in these cases, right? So either associated findings or looking for the complications in any of these cases, it's very important in the exam. Okay. These coronal images are showing very well, right? The thickening of the bowel wall, as well as featureless the descending colon and the sigmoid colon here, and the evidence of malignancy at the rectosigmoid junction. Okay. So the diagnosis here was ulcerative colitis with focal malignant lesion. That's very, very important to identify. Okay, you should not be missing this, especially in case of all the ulcerative colitis. If there is a stricture, so you need to look for the malignancy. Okay, although there can be benign strictures in ulcerative colitis, but you have to rule out the malignant lesion, especially if it is eccentric wall thickening with a stricturous lesion. You have to rule out the malignancy. So the differential diagnosis would include the Crohn's colitis or the infectious colitis. Okay, so you need to know what are the points favoring these entities. Okay, this I just put just to show what are the features in case of ulcerative colitis that you please go and read it. Usually you see this superficial ulcerations, unlike in case of Crohn's disease, you see the deep ulcerations. And yeah, these are other cases of ulcerative colitis, but the almost a pipe stem colon here. What are the differential diagnosis? Essentially includes the granulomatous colitis, right? So in case of Crohn's disease, usually the bowel wall thickening is much more. Like in ulcerative colitis, usually it's not more than 1 centimeter. It can be more than 1 centimeter in Crohn's disease, okay? And usually even creeping fat sign, you see it much more in case of Crohn's disease. Also, you can see the ulcerative colitis also. Okay, if you see the Coombs sign in the setting of the Crohn's disease, it indicates the active disease, and the infectious colitis, like pseudomembranous colitis, secondary to the Clostridium difficile infection. Okay, there can be associated ascites also. Even infectious colitis involve the entire. Okay, and the degree of mucosal enhancement and submucosal edema significantly more in infectious colitis. Okay? Unlike in case of ulcerative colitis, submucosal edema is not much. Okay, and ischemic colitis, as she was talking about, usually rectum is relatively spared in case of ischemic colitis, and you see non-enhancement or decreased enhancement in case of ischemic colitis. Okay, the other differentials would include you have to pull out the diabetic colitis, and you have to look for the diabetic line, especially if it is involving only the right colon. Right side colon, you have to rule out other colitis like neutropenic colitis, right? So we'll move on to the next case, right?
Yes, sir. Thank you, sir. Thank you, Kritika. Next case, we have Dr. Jansi. Dr. Jansi is from Kilpack Medical College.
Kilpack. It's case 5 now?
Yes, sir.
What's
Dr.
the name?
Jansi, can you switch on your
Dr. Jansi.
Dr. Jansi, sir? Can you hear
Dr.
us?
Jansi, are you there?
Yeah, sir. Yeah, sir.
Can you switch on your video also?
Hello, sir.
Yeah. I can hear you. Please present a case.
Go ahead, Dr. Jansi.
Yeah, sir. I'm here, sir.
Go ahead. You can see the screen, right?
Yes, sir.
Yeah.
Actually, I'll tell you about the history about 46-year-old male patient. Outside, he was operated for thinking that it's achalasia cardia. Okay, so achalasia cardia was the outside diagnosis, and so I'm giving you these 2 pictures. Please talk about it. Yeah, talk about the plain film first.
Okay, sir.
Yeah, go on.
Sir?
Yeah, go on. I can hear you.
Yeah. 46-year-old patient has come with who's a known case of achalasia cardia. Yeah, sir. With the frontal chest radiograph.
It's thought to be achalasia cardia. Okay. So, are you seeing any features of achalasia cardia here?
Okay,
on the plain film?
Cardia. So post the chest radiograph. Yes. Okay, sir.
Yeah.
Sir, some retrocardiac opacity is noted here, sir. Sir?
Yeah. Please go on. Yeah.
Go ahead.
Yes, sir. Some retrocardiac opacity is noted here with, and there is an NG tube which passes from the esophagus and it extends to the stomach.
Mm-hmm.
And there is a mild blunting of the right pleural effusion. Then in the barium films, we can see nasogastric tube which is extending to the stomach again, and there is an elevation of the left OG junction. I mean, there is an elevation in the esophagogastric junction, and there is again a retrocardiac opacity noted in the barium swell also.
Mm-hmm. Yeah. Go on. Sometimes we keep quiet, so we want you to tell everything. Like when present positive findings, relevant negative findings, diagnosis, differential, what you want to do next. So you have to describe everything. Till that time, we may keep quiet. Okay. So that doesn't mean that we are not hearing. Go on. Hello, are you there?
Jansi, can you
Dr.
hear us?
Murali?
No, your mic is not
Oh.
working. Jansi, we are not able to hear you. No, no.
What should I do, Dr. Murali?
No, 1 second, sir. Can you log out and, can you just speak without the headphones? Let's try. Is it a laptop or a phone? Laptop. I think the laptop will pick up its own mic. Just try.
She was doing fine all this time.
Yes.
Suddenly, how can it go? I don't know.
I think it's more of an internet issue than anything else, sir.
Okay, yeah, that's right.
Yes. Jansi, can you hear us? Can you hear us?
Hello, sir.
Yeah,
yeah,
we can hear you
Jansi.
now. Go ahead.
Hello, sir.
Good to see you back. Yeah, present completely. Yeah, you're halfway through.
We can hear you. Go ahead.
Hello, sir.
Yeah,
we can
we
hear
are
you.
hearing
We
you.
can hear you. Can you hear us?
Please go on. Hello, we can hear you, Jansi. Dr. Jansi?
Hello, sir.
எங்களுக்கு கேக்குதம்மா நீங்க பேசுறது. நாங்க பேசுறது கேக்கலையா உங்களுக்கு?
சார் ஹெட்ஃபோன் போடும்போது நீங்க பேசுறது கேக்குது சார், பட் நிறைய கிராஸ் டாக்ஸா இருக்கு சார்.
Okay, try once again.
திருப்பி ஹெட்ஃபோன்ஸ் கனெக்ட் பண்ணிக்கலாம் சார்.
Yeah.
ஓகே சார்.
Dr. Jansi, can you hear me?
She's just connecting, sir. 1 second.
Dr. Jansi, can you hear me?
She's just connecting.
Yeah, sir. I'm hearing you, sir.
Go ahead. Yeah.
Go ahead, Dr. Jansi.
Sir, it's a frontal radiograph showing mild retrocardiac opacity, and we can see an NG tube passing from the.
Yeah. Those things we heard already. Go ahead.
Sir, there is an NG tube noted traversing from the. It's a frontal radiograph showing mild.
1 second, Jansi, we're hearing an echo of this. Sir, in what did you log in?
Yeah. Hello.
Now we lost her.
I think we can come back to this case later. I think we can go to the next case and come back to this when she's ready.
Yes. Yeah. Jansi, you log out and log in later. We'll just finish the next case.
Okay. Is the other candidate ready for the?
They've also not logged in, sir. 1 second. Yes.
Okay. So then I have to wait for the Dr. Jansi only.
No. We'll do it now, sir. Hello, are you presenting now? Just log in now. We're waiting for you.
Is it candidate 6?
Yes, the candidate 6. She's just coming, sir.
Okay. So we'll go to that and then we can come back to this if there is a time.
Yeah.
Hello.
Yes, we can hear you. Dr. Divya, right?
Yes, sir.
Yeah, this is Dr. Divya from CMC Vellore, sir. Yeah.
Good.
So my video is not working.
No problem.
No problem. Anyway, we are not seeing you.
Present the case.
Are you able to see the presentation?
No, sir. Actually, I can't see the presentation.
Oh, God.
Oh my God. Okay, so I'll get one more PGC. Hold on, sir. Just a minute.
Yeah, no problem.
Sir, the other PG is joining. 1 second. Meanwhile, sir, everybody was asking a question about that pneumoperitoneum. You said chest X-ray is more sensitive now, so they wanted to know the
Yeah.
reason we missed on that.
Actually, the X-ray is where you center is very important. No, in chest X-ray, it's almost razor tangential to the level of the diaphragm. Okay, X-ray is tangential to that, so you'll be able to appreciate it better. Whereas in case of abdominal radiograph, no, it's razor not tangential, so you may miss very subtle the pneumoperitoneum there. Okay.
Yes, sir. Yes.
So are they able to hear? Okay. So it's candidate 5 or 6? No.
Candidate 6, sir.
6, huh? Okay.
6. Hello? Yeah, you have the link, no? Yeah. Same link, students link, yeah. Yeah. You have joined now, no? Yeah. Dr. Seetham, can you hear us now?
Good afternoon, sir.
Good afternoon.
Hey, good afternoon. Dr. Preetham, is it?
Dr. Seetham, sir. He's from Rohtak.
Seetham, okay. Fine. Okay. Dr. Seetham. Yeah,
Yes,
please go ahead.
Sir, where I will see the slides, sir? Yeah, I just see my phone.
Your slide is not coming. Sir, probably we have to...
log out and log in?
Your screen share alone, if you can do it again, sir. Yeah.
Screen share, huh?
Yes.
Are you able to see?
Yes, sir.
Yeah.
Yeah, Dr. Seetham, go ahead.
So I have provided with a chest X-ray and X-ray abdomen and CT of a 11-year female who has complained with pain, abdomen, fever, and cough. With that, on the frontal chest radiograph, it is showing a homogeneously radiopaque shadow that is noted and bilateral side in perivertebral region, and that is going from the chest to the abdomen, suggestive of abdominothoracic sign positive on this side, and the margin is lobulated, and we are not able to see the descending thoracic aorta. Probably that is silhouetting descending thoracic aorta. And with these two signs positive, I will think of this is a posterior mediastinal lesion postoperative lesion, and with that there are homogeneous consolidation or maybe opacity noted in right lower zone and left lower zone, in some areas in the left lower zone as well. But these are not silhouetting cardiac borders. And with that, the bilateral CP angles appear normal as sharp, so no evidence of pleural effusion, and no other mass lesion or nodule noted in bilateral lung fields. And trachea appear to be central in position. And when I magnified in my mobile, so that is showing some diffuse periosteal periostitis, or might be some newborn formation around distal in the lower thoracic vertebrae.
You're talking about here?
Yes, sir. Yeah. And there is the little bit osteopenia is present, and there is on the left heart border there is the pulmonary arterial.
So, yeah, go on. No, don't give too much of pause, no, when you're presenting. There should be continuous flow of thoughts, no?
Yeah, actually, three findings are there. One is the perivertebral shadow.
Okay. Before that, I just want to ask you, what is that thoraco-abdominal sign?
Thoraco-abdominal sign is a type of silhouetting, and the scene is whether it's a posterior mediastinal lesion or a middle anteromediastinal lesion. It describes that.
No. It is not to differentiate the posterior mediastinal or anterior mediastinal. So what does it tell you? Why it is called thoraco-abdominal sign?
Because the space is continuous from mediastinum to the abdomen. So any lesion, any collection, any soft tissue that will go from thorax to abdomen.
So what happens?
Sir?
What is the contour? What is the margin in thorax and what is the margin in abdomen?
What is the margin?
Margins. How can you define the lesion going from the thorax to abdomen? No.
Yes, sir.
So what is it about thoraco-abdominal sign? Like, for example, in this case, you're seeing the margins very well in the thorax now.
Yes, sir.
As it is coming down, the margins are getting blurred. Okay.
Blurred. Yes, sir.
Yeah.
Because the density between air and the soft tissue is well delineated in thorax, but when it go down the abdomen, the soft tissue density comes, so it blurred more.
Okay. And there are some exception to it, some lesions going from the thorax to the abdomen.
Yes, sir.
There are some exception to this thoraco-abdominal sign. Do you know what are the exceptions? Like, for example, here in abdomen, can you read this abdominal film?
Yes, sir. The abdominal radiograph showing there is a homogeneous soft tissue density that is noted around perivertebral region here, sir, on right side.
Very good.
And that also on left side, that is small area is present as well.
Yeah.
So that is same considering that is considered with similar to the thorax. And another is there is all the bowel gases are going down, that is compressed down, just because there may be hepatosplenomegaly that is compressing the bowel shadow.
Okay. So if it is a thoraco-abdominal sign, no.
Yes, sir.
Usually when it's going towards the abdomen, the margin of the lesion gets blurred. Here it's not getting blurred. Is it giving you any clue?
The density is maybe high.
Density is high. Okay. So what is the differential that you want to keep at this stage, and then how do you want to proceed?
Sir, the important negative finding is there is no calcification, abdominal calcification in the abdominal X-ray to rule out gallstone is not there, and there is.
No, what is the age of the patient?
Sir, 11 years.
11 years.
So with this
you have the
finding,
lesion. You have the lesion in thorax. You have lesion in abdomen. You're telling it's posteriorly located.
Yes, sir.
Do you
So
have any
the first
differential artistic?
age patient present of pain, abdomen, and huff and like that. I will
There's
think
some
of
background
any
noise,
hemolytic.
Dr. Murali, there's a background noise.
On the audio, I think Dr. Jansi, can you just switch off your audio?
Yeah, please go on, Seetam.
So with this finding, I will think of extramedullary hematopoiesis, and with the age group, I will think of any hemolytic anemia or like that.
No, first of all, the bones are not showing so much of
osteopenia,
widening or osteopenia or portioning, and even the posterior ends of the ribs are not expanded, no?
Yes, sir.
And it's not lobulated, okay?
And
so to think about extramedullary hematopoiesis may not be correct here, okay? So anything else?
Another will be, sir, can be neurofibromatosis, but there is no neural foraminal dilatation or like that.
Yeah. So anything else? Anything else?
Anything else like neuralgic tumors, multiple schwannomatosis,
Multiple
neurofibromatosis.
schwannomas. But here it looks like almost single lesion going from the thorax to the abdomen, no?
No.
Some sheet of tumor going here to there to the
So
abdomen.
plexiform neurofibroma it can be, so.
Okay. Anyway, so what do you want to do next?
Sir,
when this scenario is given, no? If you tell what you want to do next, you're covering up yourself. Okay. So what do you want to do next?
Sir, if any collection due to spinal tubercular infective collections that is going from down.
Yeah, this fine. Otherwise, looks relatively fine, no?
Fine, yes, sir. But there is no discitis type features on sclerosis.
No discitis, no disclose, vertebrae are looking fine.
Yes, sir.
No, that is okay. That is fine. What do you want to do next? Okay. So you're considering that TB also has possibility, and there's so many other possibilities that you told.
Because presence of fever and cough, I'm thinking of.
Yeah, fine. Absolutely fine. You're perfect. Okay. Don't worry. And what do you want to do next?
So to think ultrasound to whether the lesion is cystic or solid, or next is cross-sectional imaging, CT or MR.
Oh, you want to do the CT, no? Okay, that's very good. If it is posteriorly totally located and next to the chest wall, even if you can do the ultrasound to confirm whether it's a solid or cystic lesion. Okay.
Yes, sir.
So considering it as a solid lesion, you want to give any differentials? Okay. So I'll show you the video of this. Okay. I'm showing you a video of the CT. This plain
Yes, sir.
CT. Okay.
Yes, sir.
Just see this and then talk about it. And this is post contact. This is plain CT. Okay.
Yes, sir.
Plain CT. Are you seeing anything?
Few foci of calcification is there, and
Few foci of calcification. Good.
And there is some vertebral erosions.
Yeah, vertebral. You want to call it as erosion, or what do you want to call it?
Scalloping.
Some kind of scalloping. So what does it mean?
Scalloping
erosion, but
suggestive of benign. It's suggestive of benign, not aggressive.
Benign,
It's
some
not
long-standing
aggressive.
disease. Long-standing disease. Could be benign. You don't know. Less aggressive.
Less aggressive.
Usually, you don't use terminologies as benign or malignant. Okay, straight away. You don't use those terminologies. Okay. So where are you seeing the lesion?
Perivertebral region, sir.
Yeah, paravertebral. Okay. Paravertebral lesion. What is the density of the lesion?
It's hypo to iso to muscle, sir. To the
hypo to the muscle, but it's not looking like a fluid here, no?
Fluid. No, it's not like similar to fluid.
So mostly some kind of soft tissue, but is the density less than that of the muscle.
Yes, sir.
See, I'm trying to give you a clue, you know. You have to take those clues.
So
and you have the calcifications
few
also.
foci of calcification is there. So
and you talk about the scalloping and okay. I'll show you the rest of the contrast enhanced scans. Then you can talk about further. So it's a thoracic lesion in the paravertebral lesion here. Okay.
Yes, sir.
and then going down. Some areas of scalloping that you're seeing, and some areas it's probably entering the spinal canal, some extradural extension, but it's not entirely within the spinal canal. Paravertebral on both sides. Okay, not so much enhancement.
On contrast, no much.
Contrast, not much enhancing, but it's encasing some of the blood vessels here, like maybe the
perivertebral vessels, intercostal arteries,
intercostal or lumbar arteries. In some areas, it's entering the spinal canal.
So it is now entering, sir, in the down side.
Yeah, good, very good. And then, I told you most of the findings, but can you now at least you can say what could be the diagnosis here? You're seeing on the both sides, okay? You're seeing on the both sides. So neurogenic, what do you mean? Are you talking about some schwannomas, neurofibromas? In an 11-year-old child, okay? Bear always in the mind, 11-year, the age is very, very important when you're coming to the diagnosis.
But sir, there is no much of huge calcification or contrast enhancement. So neuroblastoma, ganglioneuroblastoma, these all are even excluded.
What is excluded?
Sir, multiple ganglioneuroma, neuroblastomas, sir.
Neuroblastoma, okay. Neuroblastoma usually some kind of a ball-shaped lesion or localized, not so elongated lesion like how you're seeing here. And but what is the other lesion that you said?
That
included.
Because typical pattern of enhancement is not there, no, sir. That's why I said it. That is, those are negative.
Neuroblastomas usually heterogeneously enhanced with large areas of necrosis within that. Okay.
Yes, sir.
And usually on one side it's more, but here the lesion is there on the both sides also. Some little bit on the left side, but on the right side it is there. A sheet of elongated lesion. I'm trying to give you some clue, and not so much enhancing, but the density more than the fluid, but less than that of the muscle.
So,
elongated lesion.
Neurofibromatosis.
Relatively benign appearing, less aggressive lesion.
And nerve sheath tumors, benign nerve sheath tumors.
What are those?
Neurofibromas.
No, neurofibromas won't be so much elongated like this. No, elongated lesion like this is only the diagnosis, not much. So you're having not plexiform. Plexiform usually multiple. 11-year-old child. What else? A sheet deletion. Yeah, okay. I think we have to wind up this case. I'll tell you about the diagnosis. The ganglioneuroma. Okay, the ganglioneuroma. You don't, but you said it is excluded.
Excluded. Sorry, sir.
It is not excluded. That is the only inclusion criteria here. The density is less than that of the muscle. It is having calcification, long sheet of elongated lesion. Okay, but it's causing a scalloping of the. What is the origin of this lesion, ganglioneuromas?
Sir, that sympathetic chain and parasympathetic.
Benign lesion arising from those sympathetic chain, right? Can be bilateral. Okay. So ganglioneuroma is a diagnosis in this case. Okay. It's almost very, very typical of that. So usually arise from the sympathetic chain, and especially in adolescent, it's very, very important, right? The ganglioneuromas are relatively common here in adolescent, and especially if it is vertically oriented for long, especially if it is a span of more than 3 to 5 vertebrae, you have to think about this lesion. Usually density is less than that of the muscle, hypo-attenuating lesion, not so brilliantly enhancing lesion like the other, what do you call that? Paragangliomas and all that, brilliantly enhanced, but here it doesn't enhance so much. You can see calcification in 10 to 25% of the cases, usually scattered punctate calcifications like how you saw in this case. Okay, the other differentials would include ganglioneuroblastomas. Usually less than 10-year-old people, they will have that, and usually they metastasize, whereas ganglioneuromas, you don't see the metastasis. Other neurogenic lesions, like you're talking about other neurogenic lesions, usually they have the horizontal axis very typical. It grows in horizontal axis fashion, like neurofibromas or other lesions. And even the pterodomas, usually you see the fat. You don't see the fat here. Okay, those are the differentials. I think we can move to the last case. The candidate number 5 is there?
Yes, sir. Dr. Jansi is here.
Thank you, sir.
Thank you. You did well, man.
Jansi, can you hear us?
Yeah, sir. I'm hearing you, sir.
Yeah.
Yeah.
Okay. Sir, quickly finish this, sir. Yeah.
Yeah, quickly. I'll just finish in 5-10 minutes, maybe. Okay. So you were talking about some retrocardiac opacity, no? So
Yes, sir.
one of the review or some hidden areas. You call it a review areas, no? In a chest radiograph. What are the other review areas in the chest radiograph?
Sir, apices of the lung and bilateral hilar regions and
Very
below
good.
diaphragms.
Very good.
Soft tissues, bones.
Yeah. You have
are
to
the
look
review areas.
very carefully.
Retrocardiac.
Where is called review?
Sir, usually these areas will be missed on seeing the radiograph, sir.
Yeah,
So,
you can't see anything. You have to go and have a second look at these areas. You have to review it. Sometimes there may be lesion in the subdiaphragmatic region or retrocardiac region like this. Okay, so although it was thought to be achalasia cardia, but it doesn't have a very typical pattern of achalasia cardia. No, even in the plain radiograph as well as here in barium. I think I'll show the video of the barium. Okay.
Okay.
Yeah. It's not very typically looking like achalasia cardia. How you're seeing there. Okay. See the video and then talk about it. What could be this?
sir,
So-
the esophagogastric junction appears to be at the higher level, sir.
Uh-huh.
And
Yeah,
there is a retrocardiac opacity is there.
Yeah.
And mildly dilated esophagus.
Very good.
There is appears to be there is air fluid level.
Where is the air fluid level? I'm not seeing, madam. So are you already thinking that it's hiatus hernia or something like that? Why you're telling air fluid level or within the esophagus you're talking about? No. Okay. Not in the opacity, no?
Not in the opacity, sir. In the esophagus.
Oh, okay. That's fine. That's fine. Okay. That means that there is hold up. Okay. Please go on. You're in the right track. I probably was trying to mislead you. I don't know. Yeah. You talk about the retrocardiac opacity here. So what is your differential at this point of time?
Sir, retrocardiac opacity and in
Yeah,
this
that-
setting, it could be a hiatus hernia.
No, some additional images are there here. Please have a look at it. Okay. Hiatus hernia. What kind of hiatus hernia you're talking about?
Sir, if the OG junction is 2 centimeter above the hiatus, then it could be sliding hiatus hernia.
No, do you think it's a sliding hiatus hernia here? And already your tube is also in position, no? Is this the picture of a sliding hiatus hernia? And why barium is not going there? If it is sliding a hiatus hernia. Yeah. Anything else you are seeing here? Okay. So I'll try to give some clue. It may be some extrinsic impression on the esophagus. Okay.
Yes.
So I'll try to give you some clue. Take this clue and finish it. Are you seeing anything here?
Yes, sir.
What are you seeing?
Well-defined radio opacity noted in the retrocardiac region.
No, that is okay. But
that is displacing the esophagus and displacing the esophagus to the left and causing extrinsic impression over the esophagus.
Is there any calcification, and what kind of calcification? The peripheral, you're seeing some more density, no? Can you make out? Or you're not able to make out? Okay.
Yes, sir. Yes, sir.
So what is
Sir,
your impression at this point of time?
Can it be constrictive pericarditis, sir? I don't know, sir.
It will cause impression on the esophagus. Which chamber you are talking about? What chamber is adjacent to the esophagus?
Left atrium.
So are you considering left atrial enlargement? So if it is left atrial enlargement, did you see any findings on plain radiograph? No, that you leave. Okay.
No, sir. No, sir.
Okay. So anything can occur here in a posterior mediastinum, causing impression on the esophagus like this. Okay. So what do you want to do next? You're stuck. You don't know what you're dealing with. Some lesion is there causing impression on the esophagus. At least if you cover up with saying that what do you want to do next, maybe good
Cross-sectional imaging.
Yeah. Then you have to say that. Okay. Cross-sectional images you want to see. I'll show you the cross-sectional imaging. Okay. Yeah. Riles tube or NG tube, whatever, is still there in the position here. Okay. And it's come down here. It comes down here. And now can you say that what you're trying to deal with?
Sir, once again, I want to see the videos.
No, you're seeing the video, no? Yeah. Back and forth. Yeah. What is the inner content of the lesion?
It's a cystic lesion with peripheral calcification, sir.
Peripheral calcium. Good. Very good. Yeah. So what is the differentials? In the posterior mediastinum, like is it in the posterior mediastinum or where is it? What space is it? No, what
the
space?
posterior mediastinum.
No, according to ITMIG classification. So where does this come? Does it come in posterior mediastinum or what do you call this space? This space? One is the prevascular space. One is the paravertebral.
Visceral space.
Visceral space. Yeah, the lesion is located in the visceral space. Okay.
Visceral space.
Visceral space and almost encasing the esophagus also.
Yes.
And some cystic lesion, but showing peripheral calcification. What is it?
Esophageal duplication cyst. Sir.
Duplication cyst. That's one of the good differential. But do you see the calcification commonly in the duplication cyst?
No, sir.
What is the age of the patient?
46.
Yeah. Do you see duplication cyst commonly in this age group, or what age group is common?
In the pediatric age group, sir.
Pediatric age group. Okay. So you adult patient. So what are the other differentials? What are the cystic lesion you can see here? Madam, the common things are still common. Okay. Uncommon things are uncommon.
Hydatid, sir.
Hydatid is also not very common in mediastinum. What are the common things? Yeah. Routinely you see. I think if you see some 3 to 4 days of your cases, no, you will see that. So I'll go ahead and probably give you some more clue. Come down, 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 and down, down, and down.
Sir, is it just, sir?
See carefully, madam.
Sir?
See carefully. Where are these calcifications?
Pseudocyst. Pseudocyst of pancreas.
Now you got it. In that location, especially, either it goes through the esophageal hiatus or the aortic hiatus. No.
Yes, sir.
In this location, one of the commonest things that you have to think of is the pseudocyst of pancreas. At least you should have said. So I want to see if the abdominal images to rule out the chronic pancreatitis or pancreatitis in this case, right? So it's almost going all the way up to the pancreas, and then it goes up. No.
Yes, sir.
In this patient having chronic pancreatitis. Okay. That's very good. You did very well, but I think the common things are common. You have to think common things first and uncommon things later. Okay.
Okay, sir. Okay, sir.
Yeah. So pseudocyst of the pancreas. It's located in the lower mediastinum with either access. It gets access from the abdomen either through the esophageal or aortic hiatus. Usually, you have the clinical history. A differential diagnosis, as I said already, esophageal duplication cyst, but nearly 75% occur in the children. In an adult patient like this, usually not a common thing. And calcification is also not very common. Okay? The other things probably you could have said, but it's not a common location. Pericardial cyst, but not in this case with the given findings. But pericardial cyst, most often it's located majority in the right-sided and most often asymptomatic. That's the end of the thing, the end of the slides.
Thank you so much, sir.
Thank you so
Thank
much.
you, sir. Thank you,
sir.
Dr. Rajagopal
Thank you,
from
sir.
Manipal, sir, for such a detailed case discussion of almost 6 cases for more than an hour and a half. Thank you so much, sir, for your patience.
Thank you so much. At least I got some more time this time.
Oh, yes, sir. So to all those who joined, next week we are going to have case presentation, and we are also going to have a poster presentation. Along with that, we are going to have some Viva discussion. All those afternoon session in our exam, whatever happens, we are planning to discuss that. So we are going to have some Vivas discussion also next week. Please do join us same time next Sunday. Thank you so much, sir.
No, as a faculty, you want me to join? Probably.
No, I want everyone to join, sir. As for you also, sir. We'll contact you. I'm just giving this information to everybody.
No, as a faculty, I think probably next week I may not be able to attend. That is the thing.
No problem, sir. We'll find somebody. Sure,
Okay. Then thank you so much for the opportunity. It was nice sharing those cases with the students. Thank you so much, students.
Thank you, sir. Great cases. Pleasure, sir. Thank you so much.
Thank you. Bye.
So, to all those who have still joined, we are also planning to upload these sessions in the YouTube. We'll be having a private channel in the YouTube. We will be sending you the links shortly. Thank you. See you all next week. Bye-bye.